Good evening, dear friends of modern medicine profession and members of Indian Medical Association. IMA College of General Practitioners Kerala is extremely happy to continue this great mission of empowering every healer and thereby enhancing healthcare, which is the theme of Dr. M. Menon, the State President of Indian Medical Association Kerala State for the current year. We are greatly indebted to the support, wholehearted support from Dr. Roy R. Chandran, State Secretary, Indian Medical Association, Kerala State. We are also happy and grateful to each one of you for your support and blessings in this great mission. Friends, as you all know, IMA College of General Practitioners do have a WhatsApp channel, which you can subscribe, you can follow, through which you will definitely get a lot of information. Important events will be shared there, and there are a lot of things. Now, please do not hesitate to share your views at imacgpkerala@gmail.com. It's very simple. We'll be replying you in real time or at least within a few hours time for sure. Friends, essentials of every day in modern medicine. There are plenty of things. And we have been working out through a weekly webinar series, starting from the 4th June 2026. And we are so happy that the program is going on very well with the same username, same passcode, and the same link. And the acceptance for the YouTube live stream as well as the later on, views of the YouTube videos of this program is also quite encouraging. Now we are stepping another level, stepping up another level through introducing a grand round series. Our plan is to, to bring out various aspects of a single topic in a same day so that we will have a comprehensive understanding on the topic. Today, as you all know, we are covering the cancer. And the comprehensive management of cancer is not an easy thing. And we are going to listen from 8 eminent faculties. And the management of cancer, there are a lot of changes in the field of oncology, and which maybe you will come to understand within a few minutes' time. Now, let me welcome Dr. Biju Nelson, our Honorary Secretary of IMA CGP, to formally welcome the faculties.
Good evening, respected Director of Studies, Dr. Prashant CV, today's speakers, senior colleagues in IMA and dear friends. It's my great privilege to say a few words about the Regional Cancer Center, the premier institution in Kerala and a center for excellence in cancer treatment, research and education. RCC has played a reasonable role in bringing advanced cancer care within the reach of patients, particularly through its multidisciplinary approach involving medical oncology, surgical oncology, radiation oncology, pathology, radiology, palliative care, and many other specialties. The doctors at RCC deserve special appreciation for their clinical expertise, commitment, compassion, dedication, and patient care. Their contributions goes beyond treating cancer. They also educate the medical community, promote early diagnosis, conduct research, and continuing update themselves with advances in oncology. The general practitioners' interaction with such specialists is extremely valuable. We have eight speakers today, and 7 of them from RCC and 1 from Lisie Cancer Care. We have with us Dr. Madhu Muralee, Department of Surgical Oncology, Regional Cancer Center, who is speaking about lower GI cancer. And we have head and neck cancers, Dr. Malu Rafi, Additional Professor, Department of Radiation Oncology, RCC. We have Dr. Anoop T, Additional Professor, Department of Medical Oncology, RCC Thiruvananthapuram, who is speaking on lung cancer. breast cancer, Dr. Rajiv K.R., Additional Professor and Department of Radiation Oncology, RCC, will talk on breast cancer. And for about male urogenital cancers, we have the leading professor and Department of Radiation Oncology, Professor Dr. Ashwin Kumar of RCC Trivandrum. And from female genital organs, Dr. Lakshmi Das, Additional Professor, Department of Medical Oncology, RCC, will talk. About the hematological cancers, Dr. Sujit, Additional Professor, Radiation Oncology, RCC, will talk. And Dr. Arunlal, who is a head of department and senior consultant, Department of Radiation Oncology, Lisie Cancer Center, Ernakulam, which is a leading center dedicated to comprehensive cancer care, combining advanced comprehensive diagnosis and treatment, facilitating with a passion of patient care. It is therefore my great pleasure to honor and welcome our respected RCC doctors and Dr. Arunlal of Lisie Cancer Care, and thank them for sharing their valuable knowledge with IMA CGP and family. Thank you.
Thanks a lot, Dr. Biju. Now it's our opportunity to listen. Friends, cancer is a disease with lot or rather numerous misunderstanding than right understanding. There are a lot of misconceptions than proper understanding. And in the earliest era, people thought of managing cancer with surgery alone. And if the surgery is not possible, there is nothing, remaining. And there are umpteen number of situations, and situation changes like anything. Now, our each faculty will deliver talks in 4 segments. Please make use of it and please understand in that way. First is the red flags in the diagnosis of cancer, which they discuss. Then, what is the current concepts of management in their respective cancer segment. Then, what every doctor should do and should not do in respect of that malignancy when the patient is on active cancer treatment, and what we should do when they refer them for the best supportive care. It's a very crucial time. Without wasting any moment, let me proudly invite the most eminent, the passionate surgical oncologist whom I have ever met. There are umpteen number of teachers in surgical oncology. But the most hardworking, pakka professional and very nice gentleman, Professor Dr. Madhu Muralee. He is a leader of many organizations, including, Kerala Association of Surgical Oncologists. He was the secretary, the Indian Surgery Association, and there are umpteen number of avenues. He is there, and he makes sure. He was the superintendent of, our regional cancer center, medical superintendent once, and wherever he is, he make a signature. So let us proudly invite Professor Dr. Madhu Muralee from the Surgical Oncology Division of Regional Cancer Center to understand the role of surgery in cancer, focusing on, lower GI cancers. Hearty welcome, Dr. Madhu Muralee.
Thank you, Prashant. Can you hear me and see me?
Yes.
And
perfect.
Is my slide visible?
Yes, perfect.
Thank you, Prashant, for the wonderful introduction. It has put a lot of pressure on me. At the outset, let me thank IMA Kerala Chapter, IMA CGP for giving this opportunity with my colleagues from RCC. And thank you, Dr. M.N. Menon sir and Dr. Roy sir, who are the state office bearers of IMA, as well as I'd like to thank Prashant being the director of academics, as well as Biju, who is the secretary of the academics, for giving us this opportunity. Actually, when Prashant actually called me up a couple of weeks back, he actually told me to give an idea about role of surgery in cancer management. But the surprise came 2 days back when he again called me back and asked me that Dr. Geeti, who was supposed to talk on lower GI cancers, is down with dengue. So she is unable to attend this program. So can you cover that area as well? So the mandate that has been given to me is to speak about, give an introductory remark about cancer as a whole, then speak about the role of surgery and role of, what is the current status of management of lower GI cancers. But again, he told me another thing that most of the viewers or listeners would be from different specialties. Some would be general practitioners, some would be from other specialties. So they also come across cancer care and either in the time of diagnosis or follow-up or management. So give them a brief idea over. So I won't be actually going into the detail or in-depth aspects of management of each cancer because there are other speakers who will be following me to speak about specific cancer. So what I would do over the next couple of minutes is to give you an idea about what cancer where we do with cancers, management cancer is concerned. What is the role of surgery as a whole when the management of cancer is concerned? And lastly, I would touch upon lower GI cancer. So I would have 3 parts and I believe I can speak and finish off in time that is allotted to me. Now, if you look at the global picture, we know that cancer incidence is on a rise. We know from our own surroundings or our own OP practice or our own clinical practice that the number of cases that we're coming across day by day is increasing. And that's exactly what the Globocan data says. If you look at the projection for 2050, this is continent-wise distribution. You can see that all the graphs, all the continents are likely or showing an upward trend. So the incidence of cancer is increasing. The other graph that is on the other side is about different continents. That Asia, the 51% of cancer incidence over the next 20, 30 years is going to be in Asia, where our country is also a part of. So we need to expect, anticipate, and be prepared to deal with such a scenario which is going to come in under 20 to 25 years. Again, what is the Indian picture? Again, there's a projection specific for India. You can see that the incidence of both male cancers and female cancers are going to be on the rise. This is projection for 2050. And again, the mortality also is not showing any lower trend. It is also going to rise. So these are alarming features. I'm not putting the speakers to frighten you or to keep you in give you a dismal picture. But these are the facts that we need to face as practitioners of modern medicine. And we need to keep in mind when we formulate policies or we need to look forward as far as cancer management is concerned. Now, mortality, one dismal picture is that if you look at the green areas of the globe, you can see that almost all are in developed countries. If you look at African countries or our own country of India, you can see we are somewhere in the orange or the red zone where the mortality is on the higher side. So not only that the incidence is high, the mortality of cancer, specifically in our countries, is on the higher side. We need to bring it down somewhere so that we enter in the green zone. Now, how does this matter to people from the state of Kerala? You can see 2 maps of India. Now, if you look at the map from 1990, if you can see, I'm in the left side on the screen, you can see that, or the right hand, so you can see that. If you look at 2 areas, Kerala in 1990 had an incidence of 74 cancers per 1 lakh population. The largest incidence was in Mizoram, it was 89. In 2016, just look at the picture. We have moved from the yellow zone to red zone. And if you compare our state with other states, you can see that our incidence has increased to 135 per lakh. Look at Mizoram, which was at 89, is at 121. So today we can say that Kerala registers the largest number of cancers per lakh population. So our state can be considered to be the capital of cancers because of the incidence is rising, probably because of the westernized lifestyle and other eating habits, sedentary lifestyle, etc., etc. But there are so many factors. But the point I want to make is that our state stands first in terms of incidence of cancers in the entire country. Now, what are the common cancers and what is the trend that we're going to expect in the next few years? If you look at 90 cancers, cervical cancer, stomach cancer, other common cancers. Today, across sexes, both male sex and female sex taking together, breast cancer tops the list. I'm saying the data of 2016, the picture may have changed in 2026, but it's a bit old data, but we don't have the update data. So oral cancer comes second. Cervical cancer, which used to be the first cancer in the country, has come down to the third level. So breast cancer, so there's a change in the pattern of cancer, not like the incidence is increasing, pattern of cancer is also increasing, or changing. But when you look at the cause of death, stomach cancer continues to be the leading cause of death. Now, how do we move forward? I was saying what to expect in the next 10 or 15 years as far as cancer incidence is concerned, cancer mortality is concerned. So as healthcare professionals, we need to understand that we need to be alarmed by the numbers or alarmed by the situation that we are going to face, but we need to have more treatment centers, more trained manpower in cancer care, And we need to decentralize. Centers can RCC or MCC or Cochin Cancer Center or the medical college cannot handle this entire volume by their own. We need to decentralize at least part of the cancer care, at least the diagnostic part, follow-up part, decentralize, generate awareness among the common public on the warning signs, generate awareness of healthcare professionals of what are signs to look at, what are symptoms to look at, when do we need to investigate, do we need to refer the patients. At the same time, we need to bring about lifestyle modifications, which probably in the next 20 years can bring down the incidence of cancer. So this is the picture that we're looking at 2026, and this is the projection for 2050. The common cancer screening can be beneficial. We all know that breast cancer by clinical examination and mammogram can undergo screening. Colorectal cancer can be screened by fecal occult blood test or a colonoscopy. Prostate by prostate-specific antigen, lung by low-dose CT scan, oral cancer by visual inspection, and cervical cancer by HPV testing and Pap smear. So common cancer. Most of the cancers do have some screening modality, but it's common cancers in our country, and the potentials to screen them and diagnose them much earlier. But the problem is that, can we roll this screening program to the general public? From the experience I have in RCC, from my seniors, from my colleagues, we understand that screening of the general population is not practical because we are not ready for screening because of the availability of most of this test, accessibility of the common man to most of this test, and the affordability comes into picture. So as far as screening is concerned for the general population, my take would be that it is not possible to roll out a general screening program for the general public of the country, even though the incidence is on the higher side. But what is possible is that opportunistic screening or high-risk screening. So as practitioners of modern medicine, we can identify people at the higher risk. For example, a patient has been a smoker for 10, 20 years. He's at risk of oral cancer, lung cancer, or a patient who has got 2 or 3 family members with breast cancer. So if you can identify the risk factor or risk families in the population and advise them to have the screening modalities with something like an opportunity screening rather than a general population-based screening, probably we can make a diagnosis in the earlier stage and from a higher stage to a lower stage of the diagnosis itself. So we need to identify more and more people in the earlier stage itself. Now, as Prashant said, maybe 30 or 40 years back, the only treatment modality available for any cancer was surgery. But then over the last 3 or 4 decades, the cancer treatment has evolved to such an extent that a one man cannot decide the treatment of any cancer patient. That's the importance of having multidisciplinarity. A surgical oncologist, a medical oncologist, a radiation oncologist, a radiologist, pathologist, and the allied specialty. When I mean the allied specialty, it includes the palliative care physicians, the anesthetist, and so many other people need to come together, put their brains together, and to have a common program for the patient. So it is a multidisciplinary treatment that makes the difference for most of the patients nowadays. Now, moving on to the second part of my talk, where I would like to focus on what is the importance of surgery as a specialty today in the management of cancer. For the sake of defining that purpose, I would like to divide malignancies into 2 different classes. One is known as the hematological malignancies, where my colleagues will be talking about, which includes leukemia, lymphoma, where chemotherapy is the backbone or systemic therapy is the backbone of the treatment. Here, there is not much of a role for a surgeon other than taking a biopsy or tackling some complications which may develop during the management. So surgery doesn't have any role in the management of any of these hematological malignancies, lymphomas, leukemias. But on the other side, you have something known as the solid tumors, which are tumors of the head and neck, including thyroid and parotid. You have esophageal cancers, lung cancer, breast cancer, stomach, colorectal, hepatobiliary cancers, gynecological cancers, urological cancers. In most of these solid tumor malignancy, surgery has got a very important role to play with add-on improvement in the outcome by chemotherapy, radiotherapy, and immunotherapy and other systemic therapies which are evolving over the period of time. So that is the importance of surgery as far as managing tumors is concerned. Now, for the sake of proper understanding of the basic concepts of where surgery stands, I would like to divide malignancies into 3 classes. Early malignancies, which include stage 1 and stage 2. We need to diagnose patients at this stage. That's what our aim of generating awareness, lifestyle modifications is to diagnose maximum number of patients at the early stage. Then comes a locally advanced stage, which we call stage 3. Then comes what is known as the stage 4, which is metastatic disease. Now, from here onwards, I would like to tell you what is important surgery. Now, first, let me touch upon early stage disease. When I say early stage disease, includes stage 1 and stage 2. So early stage disease, the importance is that it is easy to treat, because most of these early stage cancers can be treated by a single modality treatment. In spite of the fact that I told that multidisciplinary treatment should be the protocol, but it can be treated by a single modality. The single modality may be surgery or a combination of chemoradiotherapy. And this early stage patients, if you are treating properly, the outcomes are better, the survival is better, and the financial toxicity both on the patient, his family, and the government is also on the lesser side. So our idea should be to diagnose maximum number of cases in the early stage. Treatment becomes simpler, outcomes are better, and the financial toxicity is also on the least side. Now, early stage disease, I would say I said single modality treatment. So as I said earlier, most of the solid tumors can be managed by surgery as a single modality of treatment. But chemoradiotherapy can also form a single modality treatment where surgery need not be done. For example, there are esophageal cancers, laryngopharyngeal cancers, cervical cancer. When I say this, I mean single modality is chemoradiotherapy. And I don't mean that surgery is only single modality treatment which can be tackled for early stages. Chemoradiotherapy can also be a single modality. So there is no combination of surgery with chemotherapy, surgery with radiotherapy when it comes to early stage disease, purely early stage. But again, I would like to put across that I am talking about general cancers. There can be changes here and there, but I'm talking generally about common cancers. So what are the areas where primary surgery can be the sole modality of treatment? For example, in head and neck cancer, stage 1 and stage 2 oral cancers, thyroid cancers, parotid cancer, lung cancer, esophageal cancer. Breast, I put it in yellow because Rajiv would tell that even in early breast cancer, you need to have a multimodality treatment, including systemic therapy, hormone therapy, and other forms of therapy. Sarcomas, bone tumors, GI cancers like stomach cancer. Most of these tumors, if they are diagnosed in early stage, when I say early stage, I specifically mean stage 1 or stage 2, that is T1, T2, N0. So most of these subsites of cancer, if we can diagnose the patients in the early stage, surgery alone would suffice as a single modality treatment, except for some areas where there can be difference, where my colleagues will be putting their thoughts after this. Now, next I will touch upon stage 3, which is locally advanced cancers. When it comes to locally advanced cancer, it is not about surgery alone. Surgery alone cannot give you any good outcomes. It has to be combined with chemotherapy, radiotherapy, and other biological vehicles, immunotherapy, and systemic therapy. That's what I said. If you can diagnose a patient early stage, a single modality would suffice. The treatment becomes easier, and the outcomes are good, and toxicity is lesser. But when it comes to stage 3, the outcomes are not as good as early stage disease. Treatment becomes more complex, and the financial toxicity is on the higher side. And each of this treatment modality has its own medical toxicity on the patient as well. Now, when it comes to locally advanced cancer, as practitioners, you should understand that, as I said earlier, it is not surgery alone. It has to be combined with other modalities of treatment, which may be in the form of neoadjuvant chemotherapy or neoadjuvant radiotherapy, then comes surgery. In some situations, you may operate first, adjuvant chemotherapy, and give radiotherapy after that. So we need to understand that multidisciplinary treatment is the way forward, and the patient should be, or the case should be discussed in a multidisciplinary forum, and all the specialists should come together and decide when the surgery should be fitted. It can be after the neoadjuvant chemotherapy or radiotherapy, or surgery can be operated, or patient can be operated first, followed by adjuvant chemotherapy and radiotherapy to make it as simple as possible. So surgery has to be done, but it has to be preceded or succeeded by other modalities of treatment. So when surgery comes in, or when you can fit in the surgery, can be decided only by a team of doctors who are dealing with this particular disease. That's importance of a multidisciplinary tumor pools. Now, lastly, coming to stage 4 disease, it's metastatic disease. As far as metastatic disease is concerned, I know that you all would have a very pessimistic approach to metastatic disease because it's about palliation. No, it's not like that. That's one major change or one major message that I would like to all the people who are listening to this particular lecture, that stage 4 is not about palliation. It involves multiple organs. The disease has spread to the liver or lung, etc. But majority of them would go for palliation, and the outcomes are generally poor, but it's not always palliation. There is a subset of patients who we can define as oligometastatic disease. Other is a disseminated metastasis. Disseminated metastasis surgery doesn't have any role. But in an oligometastatic patient, where the metastatic disease is confined to the liver or the lung, for example, patient has got colorectal cancer, he has got 1 or 2 or 3 or 4 liver metastasis, or 1 or 2 or 3 lung metastasis. It is not palliative treatment. It is curative modality of treatment. So if you have a patient who has got metastatic disease, you don't just push him to palliative care. you need to put it across to an oncology team and see whether this patient can be operated and in the process have a better outcome. So metastatectomy is becoming a major part of the treatment protocols for stage 4 disease. And this is a message we need to give across to all practicing physicians and the healthcare professionals as well, because metastatic patients should be discussed in a proper tumor board, and the patients who can be offered radical treatment form of metastatic, which can be in the liver resections, lung resections, or whichever organ is spread to, and then given all other forms of therapy so the outcomes can be made better. So this is a message I would like to give regarding role of surgery in early cancers, role of surgery in locally advanced cancer, and role of surgery in metastatic cancer. Why surgery matters? We said about role of surgery. Why is surgery so important in the context of many cancer? Because when I talk about surgery, you would all know that the radicality of surgery is what matters. So it is about complete removal of the tumor with adequate margins all around and removal of all the nodes in the area. So this is the basic philosophy of any cancer, whether it be oral cancer, thyroid cancer, parotid cancer, esophagus, lung, pancreas, liver, colon, rectum, anywhere. This is you have to remove the primary tumor with an adequate margin and remove all the nodes. So if you compromise on any of these aspects, the outcomes are going to be very bad. So the radicality is in terms of complete removal with adequate margins, whether it's breast cancer or anywhere it's like that, and removal of the nodes in the involved area. So the importance is that if it is not done properly, if you have a positive margin, if you're not doing a proper nodal clearance, it reflects on the outcomes of the patient. So we should not be with the false notion that an improper surgery or inadequate surgery can be made up by giving adjuvant chemotherapy or radiotherapy. Adjuvant chemotherapy, radiotherapy has got its own role, but the outcomes are better if the surgery has been done properly and then the adjuvant chemotherapy and radiotherapy is given. That is the importance of the role of a surgeon. This message should go across. So I'm not saying that all the patients should be operated by surgical oncologists or a particular specialty, but whoever is doing that should be trained in dealing with that sort of malignancy, who should be aware of the concepts of radicality in terms of complete removal of the tumor and the nodal clearance. Only then the outcomes are good. Then we need to add on the other specialties for the outcomes to be proper. Now, just I would like to give you small examples of this particular point I was trying to make across. This is a breast cancer. Now, if you are looking at this graph, you can see that if the margins, there's so many studies, at least 20, 25 studies from different countries. If you look at it, you can see that the outcomes are better if the margins are negative. If the margins are positive, you have bad recurrence rate. So all these graphs show that patients who have a negative margin or a good surgery have a better outcome. Similarly, if you look at the nodal dissection, just if the nodes are less than 12 in colorectal cancer, surgeon may have done a good job, but if the nodal count is less than 12, the recurrence is higher. If you look at this particular graph, you can again see that if the nodes are less than 12, the outcomes are bad, or the mortality is on the higher side. So this is what the margin should be negative, and the nodal clearance should be as radical as possible to have proper outcomes. Again, another example from rectal cancer. If you look at this picture, 1974 to 1985, local recurrence in rectal cancer was 39%. Local recurrence. But 40% of the patients were recurring, and the survival was only 50%. But from 1985 to 1991, in the same center, they standardized the surgery, they improved the radicality in the form of total mesorectal excision, and they found that local recurrence, which was 39%, came down to 9.3%. So there was a significant reduction in the local recurrence by improving the quality of surgery. Similarly, survival, which was only 50%, improved to 71%. So by standardizing the surgery, sticking to basic concept, oncological principles of radicality of surgery, the outcomes can be improved. And then you need to add on the systemic therapy or radiotherapy, whatever the adjuvant therapy that the patient needs. So surgery is of prime importance. It's radicality in terms of the clearance of the tumor as well as clearance of nodes is very important. And so this signifies the quality of surgery is very important. Bad surgery cannot compensate for compensate by the chemotherapy, and quality of surgery depends upon to a large extent on the experience of surgeon and the volumes of the center. Common cancers can be operated in any center, but there are complex surgeries where multivessel resections, extended pancreatic resections, extended liver resections, esophageal surgery, lung surgery, complex. For example, thyroid surgery, parotid surgery, extremity surgery, or a breast surgery can be done by anybody. But when it comes to complex oncological surgeries like the organs that I said, it needs a good amount of training and high volume centers to produce the outputs that you are likely or you intend to produce. So surgery forms a backbone of treatment of solid tumors. Radicality of surgery is prime importance and cannot be compensated by other modalities. Better outcomes and the quality of life also of the patients better. Again, as I said, stage 4 disease, I said already, I just don't want to touch upon this. Now, lastly, I would like to touch upon colorectal cancer. This is common cancer in this part of the country. We have a lot of colorectal cancer. Not only that, we have a lot of colorectal cancer, a large number of young patients colorectal cancer. And I know that a message I like to give is that even though we speak about colorectal as a common entity, there are two different entities. Colon is separate, rectum is because as far as colon is concerned, the two modalities of treatment are surgery and chemotherapy. But when it comes to rectal cancer, the three modalities of treatment are surgery, radiation, and chemotherapy. So this basic concept we need to understand. Colon, surgery along with chemotherapy, rectum, surgery along with chemo and radiation. So what are the common symptoms of colon cancer? We all know that altered bowel habits are the common symptoms, but at a particular age of 60 or 70 years, most of the patients would have altered bowel habits. So how do we diagnose cancer in this patient? The only message is that if the patient's symptoms are not settling within a time frame of maybe 2 or 3 weeks of a conservative line of management, altered bowel habits continues to be there, or the patient has got anemia, then we should go for second line of investigations like fecal occult blood testing or a colonoscopy. So I would say that any patient with altered bowel habit should be kept in close follow-up, especially elderly patients. And if the symptom is not getting relieved by conservative line of management, we should go by the second line of investigation, which would be colonoscopy. Offering colonoscopy for every patient is not a practical solution. That's why I said we need to identify those patients, and then especially the patient has got a high risk in the family. So high risk includes strong family history. And these patients, I would say early initiation of colonoscopy, but not a general early initiation, high risk identification and colonoscopy in those patients would be the way forward. So after a colonoscopy and biopsy, what is the next investigation that we do? We call for a CT scan of chest, abdomen, pelvis, and then classify patients into early stage disease, locally advanced, and disseminated. And each of the stages different managed. Early stage goes for surgery, locally advanced stage goes for early stage goes for surgery alone. Locally advanced goes for surgery followed by chemotherapy. And as a metastatic disease is not always palliation. Among the patients, you need to identify oligometastatic patients where surgery for the metastasis can be done, liver resection or lung resection can be done along with other systemic modalities of treatment. And when it becomes disseminated metastatic disease, surgery doesn't have any major role, and the role goes for medical oncology and the radiation oncology. So this is the general scheme of managing colon cancer, where surgery along with chemotherapy is the backbone of treatment. But when it comes, and again, after treatment of a patient with colon cancer, you need to have colonoscopy every 3 years and CE examination every 3 months, every 6 months, and then annually. So first 2 years, you keep on close follow-up, then the frequency of follow-up comes down. So CEA forms the backbone of following a patient for colon cancer. It's a very easy thing which can be done in any center, and we need not send the patient to a tertiary center or a higher center for screening after a patient who has undergone treatment for colon cancer. CEA and once in a while colonoscopy is the way forward. Say again, if you look at the outcome trends, it shows that better outcomes in terms of localized disease, and when it becomes metastatic disease, the outcomes are poor. Lastly, rectal cancer. Again, as I said, the treatment is about combining surgery with radiation and chemotherapy. Again, what are symptoms? Rectal cancer is one cancer where I would like all of you to put in a more effort in terms of identifying them in the early stages, because the symptoms are more obvious than the colon cancer, because any rectal cancer patient would have symptom of bleeding at least 3 or 4 or 5 months ahead of the actual diagnosis of the disease. We are missing out the diagnosis, thinking that the rectal bleed is because of hemorrhoids or fissure or something like that. So a simple clinical examination, simple per-rectal examination, or a simple proctoscopy, which is an OP procedure, can diagnose most of the rectal cancer. But unfortunately, we are missing out because I find that there is a significant delay in diagnosis of rectal cancer. Colon cancer, pancreatic cancer may get delayed because symptoms are not that obvious. But rectal cancer patients has a very important symptom in the form of bleeding per rectum. But there are so many other diseases that can produce bleeding. Probably we're confusing with that. So if we can do a proctoscopy and a PR examination for every patient with bleeding PR, we'll diagnose a large number of patients in early stage. Because if there's a delay of diagnosis, the outcome changes. And this graph shows that if you have a 2 to 4 months delay, then the outcomes are better. But if the delay goes beyond 8 months, the survival probability comes down significantly. So delaying the diagnosis in rectal cancer is bringing down the outcomes or making more of the patients into locally advanced stage. If we had done a proctoscopy or a proper rectal examination, the earliest symptom of bleeding PR with the patient, other symptoms patient may ignore. But bleeding from any orifice, every patient takes it very seriously. And we have seen that most of the patients had attended some physician or practitioner in the past, but a proper clinical examination or proctoscopy was not done because they were being managed as hemorrhoids or piles or something like that. So my message is that any patient with bleeding PR, at least at the first instance itself, it's not like doing a colonoscopy or some advanced investigation, just putting a finger in the rectum of the patient, seeing for any lesion, or a proctoscopy, which is an opaque procedure. So at least we can increase. So in RCC, we have seen that only about 3% of rectal cancer patients are coming in early stage. 3%. 76% are coming in a locally advanced stage. When comparing to breast cancer, about 30% coming in early stage, 62. Even still, that's a dismal picture. 62 are still locally advanced. I'm just comparing breast cancer with rectal cancer. A large number of rectal cancer are being diagnosed in locally advanced stage in spite of having an obvious symptom. So if you can just flip this across and do the proper clinical examination, probably about large number of patients can be diagnosed in the early stages. And as I said earlier, stage 1 and 2, surgery alone, which is curative. Stage 3, you had to combine surgery with radiation chemotherapy. Stage 4 is palliation, except for the oligometastatic disease, which we have to identify and treat them properly. So early stage, surgery alone. Locally advanced, surgery is not the first modality. Locally advanced rectal cancer goes for chemoradiotherapy, and then this is a very important message I want to give across. Rectal cancer is not about operating. I see many patients asking me to operate them at the earliest possible date. No, rectal cancer, if it is locally advanced, it's not about operating them as early as possible. It is about giving them proper neoadjuvant chemoradiotherapy and then taking up the first surgery. So it is not about surgery first. It's about timing of the surgery. When it comes to early rectal cancer, it is surgery. There's no doubt about it. But when it comes to locally advanced cancer, it is not about timing or it's about as fast as possible to get operated. It's about when you time the surgery in terms of neoadjuvant chemotherapy. Last day I said metastatic disease. It is oligometastatic. Please give an option to the patient to get operated, or tell them that there is an option of getting operated and send him to a center where metastatectomy or advanced surgeries can be done. Disseminated disease is about palliative care. So the way forward, as I said in the initial slides, we are looking at 2015 numbers are going to increase, but we need not be not pessimistic about that. We need to improve our manpower, train manpower, awareness. Some more and more centers need to come up. And again, small symptoms of cancers, which we need to identify and investigate them properly. We can at least diagnose more and more in the early stages. And if we can diagnose early stages, the treatment becomes simpler, the outcomes are better, and the financial toxicity on the exchequer, I mean, the exchequer means the patient as well as the government, because government is paying a lot of money. As well, if you look at RCC, about 75 to 80% of patients are on government schemes. Government is pumping in crores of money for the treatment, but most of them into locally advanced and metastatic. But if they can come down to early cancers, the treatment cost will come down. So it will make the life of the patient much more easier. Thank you so much.
Thanks a lot, dear Dr. Madhu Muralee. It was in fact a Herculean task. We understand that it is for you to, introduce the topic and give an overview about lower GI cancer and particularly role of surgery. Friends, whenever we see a patient as a doctor, usually the consultation ends in a few minutes, almost half an hour. Now, what happens when a surgeon, it's something like a train. Surgical train takes a time of train journey. We, the modern medicine profession, Indian Medical Association and the College of General Practitioners, salute Professor Dr. Madhu Muralee, taking him as an icon of every surgeon who is working in the arena of surgical oncology. We are proud of your support, your effort, your energy and enthusiasm. Thank you very much. Thank you. Please stay online for clarifying some questions. Next, now it's like a Vande Bharat journey. We have to go quick. Our primary session is over. Now, next, the oncology in primary care with respect to the management of upper GI malignancies. We have a very nice doctor, a senior consultant radiation oncologist and head of the department there in Lisie Cancer Center. A single word about Lisie Cancer Center, which I must say, Lisie Cancer Center contribution through Lisie Pharmaceuticals is addressing the need of morphine requirement in pain management sector in entire Kerala, except regional cancer center, even partly to regional cancer center as well. So we are proud of Lisie leadership and we are so grateful to Dr. Arunlal, and I offer a hearty welcome to you, Dr. Arunlal. Over to you.
Thank you. Thank you, Dr. Prashant, for that kind introduction. I believe I am audible.
Yes.
Is it clear? Thank you.
Yes, perfect.
So, if so, I will proceed with the presentation. So, basically, it's always difficult to follow Dr. Madhu Muralee. In fact, I learned a lot over the last 15 minutes hearing him speaking. It was a revision of sort for me, to be honest. So, in the next 15 minutes that is allotted to me, we will be covering the upper GI sites. Mainly, I will be focusing on four different malignancies. One is esophagus, second is the GE junction and the stomach, third is the pancreas, and the fourth is the HCCs. So, these are the four cancers I will cover in upper GI. Now, understand that even in esophagus, the management of cervical esophagus is different from the management of lower esophagus. So, this differentiation exists. But we will try to cover these topics in briefly. So, I will try to take you through the basic etiology, the epidemiological shifts, what is happening with respect to the early detection and clinical presentation. And Dr. Prashant wanted me to talk about the treatment approaches to each individual malignancies in a general way, and what will be the way in which a primary care physician will be able to help this pathway. So, when it comes to when it comes to, I think I am okay. When it comes to the etiological factors, as we all know, in esophagus, the most common reason is smoking. Other than that, alcohol, chronic GRD, all comes into the picture. When it comes to the stomach, also the most common etiology is smoking and alcohol in our situation. But H. pylori infection is, of course, one of the commonest factors that results in stomach adenocarcinomas. When it comes to liver, if you go through the literature, the most common factor that is given is always the hepatitis B virus. Now, this is because if you look at East Asia, where actually the hepatocellular carcinomas are the highest load, so the hepatitis virus is very common in that area, and that leads to increased liver cancers in East Asia. But when it comes to our population in Kerala, what we are seeing is there is a large amount of HCCs associated with metabolic steatohepatitis. So the diabetes leading to fatty liver, leading to MASH, leading to cirrhosis, leading to HCCs is very common in our part of the world. And if you look at pancreas, again, smoking and alcohol are non-risk factors, but chronic pancreatitis is also another risk factor. If you look at the entire oncology, now there is an increasing understanding that chronic inflammation is the key driver of carcinogenesis across many sites. And then if you look at what is actually happening to individual malignancies, world over, the esophageal squamous cell carcinoma is actually decreasing. Now, that is probably because of the reduction in tobacco smoking. We are seeing so many young gastric cancer patients, just like so many young colorectal cancer patients. We really don't know what is driving that change. Is it something with our food habits, life habits? But definitely, young gastric cancers are definitely increasing. If you look the world numbers, actually gastric cancer incidence is decreasing. That is because there is an aggressive screening happening in East Asia. Again, Japan and Korea has got an aggressive endoscopic screening and eradication of H. pylori. So if you look at the overall world numbers, the number of gastric cancers are actually decreasing. And as I said in the previous slide, in HCC, what we are noticing, at least in India, is that there is a shift from the viral hepatitis related hepatocellular carcinoma to a MASH related hepatocellular carcinoma. So these are the four broad trends that we are seeing with respect to individual cancers in our community. Now, as you all know, and there is no real reason to teach you about what is the presenting symptoms or warning symptoms for these diseases. The only problem is these are not the warning symptoms of this particular disease as such. So when you look at esophagus, it is definitely progressive dysphagia that is the warning symptom. But the problem is that by the time the patient actually presents to you with dysphagia, most of the time it is a T3 disease. It is very, very unlikely for you to do an endoscopy for a T1 or a T2 esophageal cancer. The only situation where that happens is when you are doing an endoscopy for some other purpose and then you find an esophageal cancer. So that is how you pick up a T1 esophageal cancer. And when you come to the stomach, again, the most common symptoms are dyspepsia and early satiety. And of course, if there is a patient with melena and chronic anemia, most of us will be advising an upper GI endoscopy to this patient. When it comes to liver, again, what you need to look at is if the patient is cirrhotic, although there is no recommendation as such for regular cross-sectional imaging, like an annual CT or an annual AFP is not a part of any screening recommendation. What we are increasingly seeing is that may be useful because an ultrasound often may not pick up many of the HCCs that we are seeing in our community, especially the one associated with MASH. And when it comes to pancreas, again, the most common presenting symptom right from the time of UG, we know that is painless jaundice. Again, there is no need for revision for such a community, but an adult onset diabetes, somebody who at the age of 70 suddenly develops diabetes, or somebody who is having a very good glycemic control suddenly have a loss of their glycemic control. So these are the points that you should be thinking about when you're suspecting these malignancies. Now, once you are suspecting a malignancy, the dictum is the same. So this applies to any session that you will be having today. First, you need to confirm the diagnosis, and then you need to stage the cancer. So these are the fundamental rules of any malignancy management. So when it comes to an esophagus, you will need to do an upper GI endoscopy and do a biopsy. And in an esophagus, you need a PET CT scan for staging. So these are the steps that you need to take when you're diagnosing an esophageal malignancy. Again, when you're looking for a stomach or a GE junction tumor, the pathway remains the same. You need an upper GI endoscopy. You need to take a biopsy. You need a PET CT, and probably you need a diagnostic laparoscopy also as a part of the staging. And it is a recommendation from all the groups to do it in a locally advanced non-metastatic disease. When it comes to a pancreatic malignancy, again, you need to look at the CA19-9. You need to look at the patient's liver function test. You will try to get a endoscopic ultrasound guided biopsy. And the most important investigation for this is a proper CT, a proper triple phase CT with a delayed CT for us to understand the whether that particular pancreas is resectable or not. So that is the most important point as far as pancreas is concerned. Now, what differentiates liver from almost all the other malignancies that you may hear today is that in a liver patient, you routinely don't recommend a biopsy. If you actually ask for a triple phase CT scan or a triple phase MRI scan, if they have got that classical radiological pattern, arterial enhancement and portal washout in a cirrhotic patient, you do not require biopsy. So that is what makes HCC different from almost all the other malignancies. So again, in an HCC, you must look at your LFT, you must do your AFP, and most institutions will be now doing a blood test called as PIVCA2, or this otherwise called as DCP. In some of the AFP non-secretaries, we may be using PIVCA for our follow-up of these particular patients. Now, once you have established a diagnosis, again for any malignancy, the next step is you must decide what is your intent. Are you treating this patient with a radical intent, or are you treating this patient with a palliative intent? If you are treating with radical intent, your aim is cure. So it has to have two conditions. This patient has to be non-metastatic, and this patient has to be fit for a multimodality treatment. So this is the idea of having a radical intent treatment. So if the patient already has metastasis, or if the patient is not fit for a multimodality treatment, then your aim is not cure, it is probably palliative. And as Dr. Madhu Muralee already taught us, one concept that we must all understand in this modern era is something called as oligometastatic disease. So if the number of Mets classically is defined as less than 5 in most literature, but it can vary. In certain situations, it can be 3. In certain situations, it can be 4. But if the number of Mets is limited, even a stage 4 patient can be treated with a curative intent. So that has been the big change in oncology over the last 10 years. And as you all know, if your intention is palliation, then you have got two goals. One is the quality of life. Second is the longevity of life. So this is generally kept for either a stage 4 patient or a patient who is not fit for undergoing a radical intent treatment. Now, once you decide what is the intent of treatment, then you have to decide this patient probably requires a local treatment. So the local treatment can be surgery, it can be radiation, it can be probably microwave ablation or TACE. Or in many of these patients, you may need a combination of any of the local treatments. Like again, Dr. Madhu already mentioned, you may need neoadjuvant chemoradiation followed by surgery, or surgery followed by adjuvant radiation. So in a curative intent treatment, a local treatment is always needed for cure. So depending upon individual malignancies, you need to decide what is this patient's local treatment, and depending upon the patient's requirement, you have to decide what is his systemic treatment. So systemic treatment, what we commonly know is chemotherapy. But like we all know, there is now immunotherapy, targeted therapy, and many of the other treatments which you will be hearing throughout the course of this sessions. So the last two slides, what I've been trying to say is, once you have a patient, confirm the diagnosis, stage the patient, decide on the intent of treatment. And once you have the intent of treatment, understand that this patient may be requiring a local treatment as well as a systemic treatment. So this holds for all the solid malignancies that you will be hearing today. Once it comes to esophageal carcinoma, the fundamental management principle is, first we must establish a feeding pathway. This patient has dysphagia. This patient has got nutritional issue. So you must either get a Riles tube or an FJ or a PEG in. If it is not a surgical, if it is a surgical candidate, we don't usually keep PEG, but otherwise we can keep a PEG. Or in certain patients, it may be stenting. But either way, the first priority is that we must find a way for the patient to actually eat properly. Then only you can treat the patient properly. Now, as I said before, you can divide esophagus into cervical and upper thoracic, mid and lower thoracic squamous cell carcinoma, as well as GE junction adenocarcinoma. So if you look at the broad management principles, why this differs is, in a cervical and upper thoracic esophageal carcinoma, you generally don't do surgery. So cervical and upper thoracic carcinomas are generally managed without surgeries. Mid and lower thoracic squamous cell carcinomas, if they are operable, can be managed with surgery or without surgery. Whereas if you have a GE junction adenocarcinoma, surgical approach is the preferred approach. So this is the difference that we need to understand. So once you have an esophageal malignancy, whether to do surgery or not actually is decided by the location of the tumor. Once it is a cervical and upper thoracic tumor that is above the level of the carina, generally surgery is not the primary modality. So if you go with each esophagus stage wise, if you are lucky enough to pick a very early esophageal carcinoma at the T1A stage, we can do some endoscopic resection. We don't have to go for a major surgery or major radiation or chemotherapy, and endoscopic resection is a good option. But if it is a T1B or T2N0, we can either give the patient surgery or give the patient chemoradiation. Surgery if it is a below the level of the carina, that is middle and lower esophagus, and chemoradiation if it is above the level of carina. Now, if it is T3 or not positive, so that is when it is called as a locally advanced disease. One preferred approach is something called as the cross protocol, where actually we give initially chemotherapy and radiation, downstage the disease, and then this patient undergoes surgery. So this is one option. Or if for some reason this patient cannot undergo a surgery, this patient will be taken up for definitive chemoradiation. So this is the pathway for a locally advanced T3, T4 or not positive esophageal cancer. Whereas if this patient is a metastatic patient, again, like what I told, the fundamental rule is we must find a way to make the patient eat. So we can either go for stenting or Riles tube or palliative radiation for the dysphagia relief. There are a variety of chemotherapy regimens available, including 5-FU, capecitabine, cisplatin, Taxols, and the newer immunotherapies, the nivolumab, pembrolizumab. These are all immunotherapies. You will be hearing more about immunotherapy in the lung session. So that's why I'm not wasting time there. But many of these drugs can be used in a metastatic disease. Now, when it comes to GE junction and gastric, now the difference is that usually the upper esophagus and cervical esophagus are squamous cell carcinomas, whereas the lower esophagus, GE junction and stomach are usually adenocarcinomas. But their management are somewhat similar in the sense, in a T1A, N0, M0, just like esophagus, you can do a endoscopic resection. But from T1B onwards, now there is no role for radiation or no primary role for radiation in a GE junction and gastric carcinoma. So in a T1B, N0, M0, the patient undergoes surgery. And if it is T2 or higher, the standard of care is what is called as the perioperative systemic therapy. So basically what that means is the patient will first undergo some form of chemotherapy. Then the patient will undergo surgery, and then after that, the patient will continue to undergo chemotherapy. So that is the management of stomach cancer. So differentiating esophagus from stomach is, this is adenocarcinoma. There is the primary role is for surgery, and there is no role for a neoadjuvant chemo radiation. You will be giving either chemotherapy. I mean, you will be probably giving chemotherapy upfront if it is a locally advanced disease. Now, going to pancreatic adenocarcinoma. Now, what matters here is the pancreatic adenocarcinoma management has completely changed, because now on a CT scan, you have a better way to decide whether this patient is resectable, borderline resectable, or unresectable. Now, if we again go back to our UG time, there would have been many patients whom we opened for ripples, found it to be inoperable, and then did some drainage procedure and then closed the patient. That is no more the standard. We will take a proper CT scan, assess the resectability, and a resectable pancreatic adenocarcinoma probably will undergo upfront Whipple surgery followed by adjuvant chemotherapy plus minus radiation depending upon the pathological finding. Whereas it is a borderline resectable or an unresectable patient, rather than taking this patient upfront for the treatment, we will be giving a neoadjuvant chemotherapy or radiation, downstage the disease, and then reassess this patient for surgical exploration. And if it is a metastatic disease, of course, the regimens will be palliative chemotherapy again. And just like what I told, when it comes to esophagus, feeding is the most important situation. Many of these pancreatic adenocarcinoma will be coming with biliary obstruction, and biliary drainage procedures and relieving the obstructive jaundice takes and is an important step in the upfront management of pancreatic adenocarcinoma. When it comes to liver, again, what we should know about liver is all these HCC patients are probably cirrhotic. Okay, so the most important factor is what is the stage of the cirrhosis rather than the stage of the tumor. So if your Child-Pugh score, which has albumin, hepatic encephalopathy, INR, bilirubin. So if your Child-Pugh score is actually, if it is a CPC patient, the only curative treatment for that patient is transplant. Now, if you are not able to give transplant in a child C patient, then practically no other treatment is going to be relevant, because that patient is more likely to die due to the cirrhosis rather than due to the HCCs. So that is why we say if it is an HCC with a child C liver, even if the HCC is very early, unless if you cannot do a transplant, don't treat the patient. Second most important prognostic factor when you have an HCC is the vascular involvement, whether this patient has got a portal venous thrombus or a IVC thrombus. Now, even if it is a thrombus, there are certain treatments that can be delivered, but if there is a thrombus, then surgery is definitely out. I mean, there is no role for a transplant once you have a thrombus. So these are the two things that we must understand when you have an HCC patient. Now, in HCC, we have got a variety of non-surgical liver-directed treatments, something called as radiofrequency ablation or microwave ablation. We must all be familiar. TACE, we must all be familiar. There are newer techniques called transarterial radioembolization, which is actually done by the interventional radiologist. There are techniques called as SBRT or stereotactic body radiotherapy, which is now very popular in the management of HCCs. And unlike other malignancies where chemotherapy predominates, there is no chemotherapy recommendation for HCC. You give certain tyrosine kinase inhibitors or some immunotherapy regimens as the systemic treatment options for an HCC. So when it comes to the role of the primary physician, of course, the most important help that will be required is for early diagnosis, because as again Dr. Madhu Muralee said, it is very common for us to see the rectal cancers being managed as hemorrhoids and then coming later to us. So understanding the symptoms early and timely diagnostic workup is most important. And then to have an appropriate referral pathway depending upon the system in which you are working. So if you're looking at an upper GI cancer pathway, most of the time this will be first seen by a medical gastroenterologist, because for us to get the diagnosis, either by an endoscopy or by an ES-guided biopsy, that is the pathway that will be usually followed. So that comes. If this patient is on active oncological treatment and comes to our OPD with fever, always suspect febrile neutropenia. So a CBC, CRP, and blood cultures has to be sent, and this patient has to be immediately started on a broad spectrum antibiotic as well as filgrastim 300 microgram, because a febrile neutropenia, if you give the antibiotic on time, we will be saving this patient's life. Many a time, what will happen is, these patients will go to one casualty, next casualty, and by the time they come to their treating hospital, the patient will be in sepsis. So febrile neutropenia is the one thing that is required for an active, for a patient on an active cancer treatment. That is the first thing that you should be thinking about. Nutritional support is extremely important for all these upper GI malignancies or any malignancies. The nutritional problem can be simply due to their disease, or it can be due to the treatment as well. So a proper nutrition is extremely important. If the patient is an HCC, most of the time you will be seeing them in your OPD with some form of liver decompensation. So again, managing that is an important part of our purview. Of course, pain management and comorbidities management you are all aware of. Another upper GI related complication that may come into a primary physician's purview is a patient who has had a stent coming to us with cholangitis. So if it's a pancreatic adenocarcinoma in whom a stenting has been done, always suspect cholangitis when this patient comes to our OPD. So I talked about SBRT. So this is what is called as SBRT. So this is a particular patient with a liver tumor, as you can see in this segment 8 in the upper lobe. So what we can do is we can give radiation to just that particular area, spare the rest of the liver, and cure this patient who will not have had a curative approach at some point of in a previous time. So SBRT is what is really changing the management of liver tumor these days. The other interesting treatment that you will be hearing, one will be immunotherapy, which you will be hearing more in the lung session, and the other is something called as a CAR T-cell therapy, which you will be hearing in the hematology session. Now, why I put this slide is generally CAR T-cell therapy is a particular form of T-cell treatment where you take the patient's own T-cells, expose them to the particular cells, and then give it back to the patient so that the patient's own T-cells can fight against the cancer. Now, CAR T-cell has got approvals in myeloma and hematological malignancies. The first CAR T-cell that has been tried in a solid malignancy has come in stomach. It targets a particular surface molecule called as claudin. So the first treatment for first CAR T-cell treatment for upper GI has come in stomach. So I think I have stopped it in 15 minutes. I'm not sure. If there is any doubts, I can take it now or later.
Thanks a lot, Dr. Arunlal. Friends, as we all know, it's a hectic job to finish in time. We'll be a bit, lagging in time. That's not a problem because understanding things takes a long way. And Dr. Arunlal, you did a great job. Thanks a million from IMA College of General Practitioners, and on behalf of IMA, we are extremely grateful to you. And please stay. There are some questions we'll take towards the end of the program. Okay, thank you. Friends, it's time for us to listen to the head from a passionate woman in radiation oncology, Dr. Malu Rafi. She is very active in management of head and neck cancer. So let us listen from Dr. Malu Rafi on head and neck cancer. Hearty welcome, Dr. Malu.
Thank you, Prashant, and thanks to the IMA Kerala chapter for having me here. I'll try to be quick with this one. So I'll be giving you an overview on the management of head and neck cancers. Can you see my slides?
Yes, yes.
Okay. It's not. Okay. So these are the heads on which I plan to discuss this topic. So when we talk of head and neck, these are the subsites that we are referring to. Includes the oral cavity, nasopharynx, oropharynx, hypopharynx, the paranasal sinuses, nasal cavity, as well as the larynx, and also the salivary glands. Although we have several histologies of cancers in this site, including squamous cell cancers, the salivary gland neoplasms, the skin and appendageal cancers, the thyroid cancers, melanomas, sarcomas, lymphomas, etc. The most common cancers are the head and neck squamous cell carcinomas, and they are characterized by locoregional spread. Most of them are tobacco associated and managed using a multimodality approach. Most of them, if diagnosed early, have good control rates and are also associated with significant acute and late treatment-related toxicity. Coming to the etiology, we all know that most of them are related to tobacco. Either smoked or smokeless tobacco has been implicated in this. And alcohol is also another risk factor. Viruses like human papillomavirus are increasingly becoming associated with head and neck cancers, especially oropharyngeal cancers. And in younger women who have no history of habit use. Another viral etiology includes Epstein-Barr virus, herpes simplex, hepatitis C, etc. Dietary factors have also been implicated in the etiology. Some of these cancers are associated with immunodeficiency as well as occupational hazards. Radiation exposure is another risk factor for development of head and neck cancers, for example, thyroid cancers, and they have a long latency period from the time of exposure. And in the non-exposed individuals, there are several genetic factors that have been implicated, along with other risk factors like poor oral hygiene, presence of periodontal disease, chronic trauma, and sunlight exposure, especially in lip cancers. So looking at the clinical presentation, this depends, of course, on the stage of the disease and the site of the disease. And along with that, most patients present with nutritional compromise, airway compromise, dysfunctional larynx, which is defined as presence of stridor or aspiration. And coming to the oral cavity cancers, they can present as non-healing mouth ulcers, might be associated with loosening of teeth if they arise in the gingiva. There can be halitosis and pain, difficulty in tongue movements, with associated slurring, difficulty in swallowing, odynophagia, and the presence of cervical lymph nodes. Now, these are a few pictures to show tongue lesions which are squamous cell cancers, which can be as obvious as the first picture, or small superficial but non-healing ulcer as seen in the last one. And sometimes these lesions can be hidden underneath a teeth or behind a teeth, which may become evident only upon extraction of a loosened teeth. So oropharyngeal cancers, on the other hand, can present with odynophagia, otalgia, dysphagia, foreign body sensation, a new onset obstructive sleep apnea, snoring, bleeding, and neck mass. So here you can see anterior tonsillar pillar soft palate mass in the left-hand side and a small lesion in the tonsillar fossa on the right-hand side. So some patients can present with large cystic lymph nodes. And if it is in a young patient, you have to think of whether it is HPV associated. And these cancers are known to be presenting in younger patients with no habits, and they have excellent outcomes. So currently there are attempts to de-escalate treatment in this group of patients. So laryngeal cancers present with hoarseness, dysphagia, referred otalgia, chronic cough due to aspiration, hemoptysis, or in late stages with stridor. Hypopharyngeal cancers are often present late, and like esophageal cancers, and they can present with dysphagia, odynophagia, otalgia, weight loss, and nodal disease in the neck. Nasopharyngeal cancers are a distinct entity. They are a cancer of the young and the adolescents, and also a second occurrence can occur in the 60s. They present it in the form with epistasis, a nodal early spread to the neck nodes, nasal obstruction, sometimes cranial nerve palsy can be the presenting complaint. Some patients can come with headache, and they are also known to metastasize, resulting in nausea, loss of appetite, or bone pain. So paranasal sinus tumors, the symptoms will depend on the site, depending on which patients can present with epistasis, unilateral nasal obstruction, facial pain, or very rarely cervical nodes. So the evaluation, the first thing would be a biopsy. So we should consider a biopsy if there is an ulcer with underlying induration, or if there is a non-healing ulcer of long duration with associated neck nodes, or change in the clinical picture of a pre-existing pre-malignant lesion, especially inside the oral cavity. So we have already seen this. The investigations will aim at confirming the diagnosis, staging, and of course, the baseline evaluation of the patient. There are various biopsies that can be done, but the gold standard remains a punch biopsy. And it is recommended that we do a punch biopsy from the edge of the ulcer, also including a small rim of normal tissue. And this also helps to avoid the necrotic core that is there in the center of the ulcer. So clinical examination is perhaps the most important aspect in evaluating a head and neck cancer patient, which often includes an endoscopic evaluation. This gives us an idea about the mucosal extent of the disease, occurrence of synchronous primary, which are not unusual in head and neck subsite because of field cancerization, assessment of air. This can also enable us to assess the airway and assess the need for an emergency tracheostomy in case of airway compromise, assess laryngeal function, and of course, help us in obtaining a biopsy specimen. So imaging studies, most often a CT scan would suffice in staging, assessing the nodal disease and also bone involvement. And MRI can be an usual adjunct in defining soft tissue extent better than a CT. PET-CT is not a blanket investigation for all patients. It has well-defined role in head and neck cancers, especially in evaluation of a neck node with an unknown primary and in a metastatic workup for an esophageal cancer. Dental evaluation is a very important aspect of head and neck cancer because most of them would go on to receive radiation. So you need to also extract any caries teeth, control any infections in the oral cavity if the patient has an oral or an oropharyngeal lesion. So we follow the AJCC staging system, and currently we follow the AJCC 8th edition. 9th edition is already out, which had incorporated very minimal changes compared to the 8th edition. So the management strategies are, like I've described earlier, it's a multimodality approach involving the surgeon, the radiation oncologist, rehabilitation services, as well as reconstructive services. An organ preservation approach is attempted whenever feasible. So surgery is a mainstay of management in oral cancers. In laryngeal and hypopharyngeal cancers with locally advanced disease with cartilage involvement or a pre-existing laryngeal dysfunction. In most cases, on most sinonasal cancers and in salivary gland cancer, surgery is the first and the main modality. So it can include a wide excision, complex resections, mandibulectomy, neck dissection, reconstruction, and voice processes in laryngectomy. This is a segmental mandibulectomy, and these are the various post-op images of patients with flaps and reconstructions. So radiation, again, is another important aspect of treating these patients. This can be either external beam or brachytherapy. External beam radiation is delivered in fractionated doses ranging over a period of 3 to 7 weeks, whereas brachytherapy, which is used in selected patients, we implant tubes directly into the tumor and treated for a duration of 5 to 6 days. So radiation forms a definitive treatment in oropharyngeal cancers, nasopharyngeal cancers, in early laryngeal and hypopharyngeal cancers, and in locally advanced laryngeal hypopharyngeal cancers without cartilage involvement, and also for early nasal cavity and paranasal sinus tumors. This is sometimes combined along with chemotherapy. And radiation is also used in the post-operative setting in locally advanced disease when the resection is incomplete and when there is presence of adverse pathological features. So we have evolved from 2D treatment, which used large treatment fields, resulting in severe late and acute toxicities, to 3-dimensional treatments using linear accelerators, where we have the ability to confirm the dose to the target volumes and reduce toxicity significantly, especially enabled parotid sparing. So linear accelerators are able to deliver advanced radiation techniques like IMRT, VMAT, rapid arc, tomotherapy, and the now upcoming proton treatments. So here you can see how we are able to confirm the dose to tumors located in very complex anatomical locations in the head and neck region. So brachytherapy is used in early disease with favorable histology, and they have excellent cosmetic outcome with very minimal acute and late toxicity. Here you can see a very early oral buccal mucosa lesion, which is treated using brachytherapy. This is another picture showing early hard palate lesion treated using a technique called as mold brachytherapy. Chemotherapy in head and neck has a more supportive role It is used in neoadjuvant and induction programs wherein it is given prior to a definitive treatment like surgery or radiation. And it is also used concurrently with radiation in high-risk patients and, of course, in palliative setting. The common agents which we use include cisplatin, 5-fluorouracil, taxanes, methotrexate, and gemcitabine. And the new kid on the block is immune checkpoint inhibitor or immunotherapy, which which uses the head and neck cancer cells have the ability to block the immune recognition by attaching to the immune recognizing cells in the T cells, and this is circumvented by immunotherapy or the immune checkpoint inhibitors. We have drugs like pembrolizumab, nivolumab, toripalimab, which are used in head and neck. So they are given as single agent or in combination with chemotherapy, and they are the standard first-line treatment of choice in PD-L1 positive recurrent metastatic head and neck squamous cell cancers now. And their role in curative treatment is also rapidly evolving, but their use is limited by prohibitive cost. Then the next group of molecules are the biological therapy, which targets specific receptors in these cancer cells. So the most common is the EGFR, with the drug called cetuximab being the most widely used one, which is used concurrent with radiation in patients who are ineligible for chemotherapy and also in locally advanced and metastatic setting. And we also have oral tyrosine kinase inhibitor molecules, which are given mostly as part of palliative treatment, which includes drugs like gefitinib, erlotinib, afatinib, and lenvatinib. So coming to the prognosis, this ranges from about 85% 5-year survival in stage 1 to less than 10% in stage 4B and 4C patients. So there's this known curable head and neck cancer patients form a very distinct group of patients. They are usually, they have relapsed disease following surgery, radiotherapy, and multiple lines of systemic treatment. Most of them are in poor general condition with compromised nutrition, with locoregional disease causing obstructive symptoms. They can present with bleeding due to major blood vessel involvement. And most of these patients are unsuitable for further anti-cancer treatment because of these various reasons. And most of them are only suitable for end-of-life care. And they need supportive management in the form of palliative care, social support, wound dressing, IV fluids, and antibiotics at local hospitals. And we often end up seeing many of these patients referred back to RCC or tertiary centers for various forms of treatments, and it forms a big burden for the patients as well as the bystanders. So now coming on, I'll also touch upon treatment complications. Surgery can result in swallowing and speech difficulties and shoulder dysfunction, and this can be tackled with the use of effective physiotherapy. Radiation toxicities are more sinister, with acute toxicities like mucositis, the skin dermatitis, electrolyte imbalance, nutritional compromise, and superadded infections, aspiration, etc. This is a grade 2 skin reaction. And this is all these managed with adequate analgesia. You have to avoid irritants, especially perfumed creams and soap over the affected skin. Avoid friction, use of topical steroids, control of infection. Maintain hydration and nutrition by timely feeding tube use. We have to watch out for aspiration, electrolyte imbalance. Mouth care is usually advised with saline and soda bicarb mouthwash. And we generally tend to avoid iodine-containing ointments and mouthwash like betadine ointments and betadine gargles during radiation. So radiation also has late toxicities like xerostomia, subcutaneous fibrosis, dental caries, hypothyroidism, and osteoradionecrosis. You can see how bad the condition of the teeth in this picture is. So this is the picture of a patient I saw last week in OPD with osteoradionecrosis of the mandible following an unplanned dental extraction. And you can see that in the orthopantomogram, the mandible is literally powdered and fractured. So here again, this is a late radiation-induced edema of the neck. And also this, the picture on the right shows a severe osteoradionecrosis with bone sequestrum. And all these late complications have significantly reduced with the use of advanced radiation technologies that we use these days. So prevention is the best strategy to deal with these situations. We have to advise the patients on regular neck exercises, swallowing exercises, pre and post RT dental extraction and fluoride prophylaxis is very important. And the main thing is to avoid unplanned dental extractions. And these patients need proper evaluation and assessment of risk by an oncologist. And also TSH evaluation and correction of thyroid dysfunction is also advised. So if the patient is on chemo, what do you watch out for? So there are various adverse effects that chemotherapy can produce, including mucositis, alopecia, nail changes, myelosuppression, fatigue, neurotoxicity, including cisplatin peripheral neuropathy, ototoxicity, renal impairment, especially when patients are given cisplatin. So we need careful monitoring of blood counts. We've heard already that it is important to pick up neutropenia and neutropenic sepsis early, and early administration of broad spectrum antibiotics can be life-saving. Cisplatin nephrotoxicity and electrolyte imbalance should be kept in mind when you see a patient just immediately post cisplatin administration. 5-FU again can produce mucositis and diarrhea. So talking about immune-mediated adverse effects, these are like opening a Pandora's box. So you have these drugs can produce adverse effects on most of the organs within the body. Most common being pneumonitis, skin reactions, then GI toxicities, including diarrhea, hepatitis, etc. So this is a CT scan showing how severe immune-mediated pneumonitis can become. So now coming to follow-up and rehabilitation. So majority of head and neck cancer patients are burdened with cosmetic deformity, loss of voice, late radiation toxicity, and social isolation. So rehabilitation forms the core of the follow-up for these patients. So you have to incorporate proper exercise, swallowing manuals, dental care, voice rehabilitation, and also proper advice on habit cessation for these patients. So that's all from me. Thank you.
Thanks a lot, Dr. Malu. Dr. Malu is known for her professionalism and passion towards the subject. It is so perfect a presentation. And thank you very much, Dr. Malu. Please stay online for some more time. Now let us invite yet another professional, Dr. Anoop T. He is a man of, seen oncology. There is a courage and professionalism with passion when blended together. That is Dr. Anoop. Dr. Anoop is now heading, he's an additional professor in medical oncology. He is the in charge of the, we call E-clinic, lung and, chest and gastro. Over to you, Dr. Anoop.
Thank you, Prashant and IMA for this opportunity. Can you see my slides?
Yes, yes.
Okay, so I will not be taking much time. So my role here today is I'll be talking about lung cancer from red flags to precision treatment. So I'll be focusing on recognizing suspicious presentations, avoiding diagnostic delay, and matching therapy to stage and biology. So why lung cancer demands vigilance? We know that most of the lung cancer present today is always in the advanced stage. Early symptoms can be non-specific. So we need to know what are the red flags. One of the common red flags to be identified is persistent cough. So if you have a patient with a persistent cough more than 3 to 4 weeks, always have a suspicion of a lung cancer. You should evaluate for lung cancer. And another red flags is hemoptysis, unexplained dyspnea, chest pain, then patient with recurrent or non-resolving pneumonia. You should always rule out an underlying mass lesion. Then unexplained weight loss, hoarseness, clubbing, and no new focal neurological symptoms. Then comes the role of smoking history. So we know that whenever you think of a lung cancer, you always ask for history of smoking. But nowadays, we also ask about whether the patient is non-smoker also, because so you should think beyond smoking history. That is, never smoking lung cancer is clinically important, and frequently they have driver altered mutations. So if a lady comes with non-smoker, they can have adenocarcinoma. They can have multiple mutations associated with the lung cancer. So you should think beyond smoking history. Another thing is, if a patient come with suspicious symptoms of lung cancer, you order a chest X-ray, and the chest X-ray is normal. Don't send the patient. If you have clinical suspicion, evaluate that patient. So do not let a normal chest radiograph end the evaluation when clinical suspicion remains high. So next is the diagnostic pathway of lung cancer. Most important is get a tissue to diagnose and preserve the tissue. Next is imaging. You need to have a contrast-enhanced CT chest and abdomen to localize the malignancy of a suspicious lesion. Then comes the role of PET-CT. PET-CT is central in staging potentially curable disease. Then MRI. MRI brain is important when you have symptoms of brain disease. Then comes which route to be taken for biopsy. That is very important, because you need to have an adequate histology and you need to have a molecular material with least morbidity. Then what is the role of EBUS and ES? It can evaluate the mediastinal nodal status. Then once you get the tissue, you need to send to a pathology to distinguish whether it's what is the type of lung cancer, whether it's a small cell, whether it's a non-small cell, among the non-small cell, whether it's a squamous cell, whether it's an adenocarcinoma, whether it's a neuroendocrine tumor, etc., etc. Then need to go for a biomarker testing. Then comes the staging. TNM drives the intent. If you have a stage 1 and stage 2 disease, predominantly the treatment is local treatment, that is surgery. In some case, some patient may go for SBRT to single lesions. Then when you come to the stage 3, it's a multidisciplinary decision. So it could be surgery or it could be chemoradiation, depending upon the resectability, nodal map, molecular profile, and fitness for strategy determination. Then about the stage 4 disease, systemic therapy is the backbone. You can have local therapy like radiation in selected patients like oligometastatic or oligoprogressive disease. So before calling disease unresectable or metastatic, confirm the anatomical extent and obtain adequate tissue for biopsy and molecular testing. So non-small cell lung cancer is no longer a optional biomarker testing. So biomarker is a mandatory thing in non-small cell lung cancer. So you had to go for a broad molecular profiling. The key actionable alterations include EGFR, ALK, ROS, BRAF, KRAS, MET, exon 14 skipping mutation, RET, NTRK, HER2 mutations. You can also assess PD-L1. This is because these alterable alterations have specific drugs. So we can avoid chemotherapy in these patients who are positive for this actionable mutation. Then comes, so here comes the role of comprehensive NGS. So in some patients, you may not get adequate biopsy on repeated testing. In that patient, you can go for a liquid biopsy, which can complement the tissue testing also. And if you get a liquid biopsy negative, that does not rule out an alteration. You have to go for a tissue biopsy also. Then comes the treatment part. For early stage non-small cell lung cancer, perioperative therapy is evolving. So we know that the surgery remains a cornerstone for resectable disease. But in big way, there is upcoming of perioperative immunotherapy in the early stage also. Then after surgery, you can have adjuvant chemotherapy that is relevant for stage 2 to stage 3 disease and high-risk patients. Perioperative immunotherapy has moved in the early stage for appropriate patients also. Then about the targeted treatment, you have targeted treatment in the adjuvant setting. If you are EGFR positive, you can go for osimertinib. If ALK is positive, you come for ALK inhibitors like alectinib. And in 2026, there is a practicing changing example. Libretto 3432 trial showed that adjuvant sulfatinib for RET positive in the post-resection. So this reinforced comprehensive biomarker testing in non-small cell lung cancer in early stages. Then comes to stage 3. It's a multidisciplinary by default. So first question, is it resectable or unresectable? For unresectable stage 3, concurrent chemoradiation remains the keystone, followed by consolidation immunotherapy in eligible patients. Resectable disease may consider neoadjuvant or perioperative systemic strategies, followed by surgery also. So document metastasis staging carefully. Treatment sequencing depends upon nodal stations, tumor anatomy, fitness, and biomarkers. Avoid treating stage 3 as a single homogeneous group. Then comes, what about metastatic disease? Metastatic disease can be divided into patient with actionable mutation or patient without an actionable driver mutation. So if you have a negative NGS, check PD-L1 expression. If the PD-L1 expression is more than 50%, you have a choice of immunotherapy as a single agent. And in some patients, you can combine chemotherapy also. If PD-L1 is less than 50%, it's chemotherapy combining immunotherapy is the treatment of choice. And the choice of the chemotherapy depends upon the histology, whether it's a squamous or a non-squamous variety. So squamous has particular chemotherapy, non-squamous has particular chemotherapy. Then once we give the chemotherapy, what we give is we usually give 4 to 6 cycles of chemotherapy. Then reassess the patient with the imaging modality. Once the patient is stable or progressive, stable or partial response, we can change the treatment to maintenance treatment. And if the patient is progressive, you have to repeat the biopsy and look for any targetable resistance in the progression also. Then comes patient with actionable driver mutation in stage 4 lung cancer. Use the mass targeted therapy when a validated actionable alteration is identified. Then we can have brain metastasis in patient with the stage 4, very common. So if you have a symptomatic brain metastasis, give anti-edema measures, then control epilepsy if there is an epilepsy. Then if you have a patient, symptoms are controlled, you can go for radiation, whole brain radiation if there is multiple brain metastasis with the symptomatology. If there is patient is asymptomatic with brain metastasis, check for the driver mutation. There are certain driver mutations like EGFR positivity and ALK positivity, where you have excellent drugs like osimertinib. Then if you have an ALK positive disease, you have alectinib, lorlatinib. These drugs are high CNS penetrant drugs. We can avoid radiation in those patients if you start with the lorlatinib in a patient with ALK positive disease. And you can avoid radiation-induced problems later. So next is, do not default to immunotherapy before confirming the molecular results when your driver mutation is suspected and testing is feasible. And always at progression, you should go for a repeat biopsy and check what is the cause for the failure, what is the resistant mechanism, what is it a target mechanism, on-target mechanism? Is it a bypass mechanism, or whether the histology has transformed to some other histology, or is it due to a pharmacological failure? Then there is another entity called small cell lung cancer. Small cell lung cancer has got different biology, different tempo. Small cell lung cancer is very chemosensitive, but it commonly relapses also. So small cell lung cancer we divide into 2, limited stage, extensive stage. For limited stage, we use combined systemic treatment, chemotherapy plus thoracic radiation is a treatment. Now we have there is an addition of immunotherapy also in the limited stage. Then prophylactic cranial radiation and MRI surveillance, and that should be individualized. Then the role in the extensive stage disease of small cell lung cancer, chemoimmunotherapy is the treatment of choice. And when the patient relapses, the choice depends upon the interval from the first line of treatment, prior exposures, fitness of the patient, and availability of the subsequent options. Next, about immune-related toxicity. You should recognize these toxicities early, because we know that the common immune toxicities like pneumonitis, hepatitis, colitis, endocrinopathies, myocarditis, these are very lethal toxicities. So recognizing these symptoms early is a key role. So if you have a patient with a new respiratory symptoms on a patient on an immunotherapy, don't think that it is an infection. If the patient is on immunotherapy, a new respiratory symptoms, whether it's a cough or chest, or dyspnea exhaustion, it may be due to immune-related toxicity. It could be pneumonitis. So grade severity, hold therapy when indicated, exclude infection or alternative causes, then use corticosteroids instantly, because in early cases, it may reverse the whole thing. So early multidisciplinary input is valuable for severe atypical toxicities. Then what are the common pitfalls in your practice? So one of the most common pitfall what we see is repeated antibiotics for pneumonia without radiological resolution. You treat pneumonia so many times, but no CT chest was taken, only chest X-ray was taken. Don't do that. Go for a CT chest. Look what is the underlying pathology. There will be mass behind that. Then another pitfall is biopsy performed without planning for molecular testing. Molecular testing is vital for non-small cell lung cancer, whether it's a advanced disease or locally advanced or early lung cancer patients. So we need to have a biopsy, adequate biopsy. Don't go for FNAC. Go for biopsy. Need an adequate tissue for molecular testing. Another thing is calling a patient stage 4 for an indeterminate lesion in the CT or PET-CT without confirmation when a curative treatment is possible. It is a very common practice. An indeterminate nodule, it could be due to an infection, post-infection, or a benign cause. You call it a stage 4 disease. It may be a CA colon with the lung. You call it a stage 4 disease. So that should be avoided. Then starting empirical systemic therapy before actionable driver testing is when clinically avoidable. This is because there is a common practice we have seen. If the patient is lung cancer, stage 4, patient is symptomatic, empirical anti-EGFR is given, empirical geftinib without testing for biopsy for an actionable driver mutation of EGFR. Very common practice. Don't do that. Go for testing. If the testing is positive for actionable driver mutation, you can start treatment according to the driver. So a 60-second lung cancer checklist. If you see red flags, go for CT chest. Malignancy suspected, plan a tissue acquisition strategically. Then histology and adequate tissue, pathology and comprehensive biomarker testing and PD-L1 testing. To stage accurately, go for a PET-CT plus or minus MRI brain. Mediastinal staging where appropriate. Then MDT decision. MDT decide whether this patient is resectable, locally advanced or metastatic, then take appropriate action. Then match therapy to stage, driver, PD-L1, comorbidity, then patient calls. And if the patient is at progression, restage the disease, rebiopsy, liquid biopsy when feasible, reassess biology, then treat. These are the 60-second lung cancer checklist. So what are the take-home messages? Early recognition is a clinical responsibility, not just a screening issue. Tissue acquisition should be designed around the treatment decision. Staging, histology, molecular profiling, PDL1, now the form of core treatment framework in non-small cell lung cancer. For stage 3 lung cancer, multidisciplinary decision. In 2026, biomarker-directed perioperative treatment continues to expand, so making comprehensive testing, genomic testing increasingly important today. So these are the take-home messages. So I'll quickly give flashcards, red flags, which symptoms should prompt urgent evaluation: hemoptysis, persistent cough, unexplained weight loss, recurrent non-resolving pneumonia. Go for evaluation. Second, about staging. Best imaging modality for a potentially curable non-small cell lung cancer is CT or PET-CT. You can combine these also then with MRI brain if we are going for a radical treatment. So invasive media staging is needed in early stage disease. Then about tissue. Why plan the biopsy route carefully? Because you need enough tissue for histology, PDL1 and molecular profiling. Fourth, biomarker testing. You should go for actionable non-small cell driver testing. EGFR, ALK, ROS, BRAF, KRAS, MET, RET, NTRK, HER2, because all these agents are got specific treatment. Then about the plasma. Can a negative liquid biopsy exclude a driver? No. A negative plasma results may reflect a low ctDNA, so tissue testing remains important when feasible. Then about stage 3 disease. What is the first MDT question in stage 3? Is it resectable or unresectable? So stage 3 is heterogeneous. Then about stage 4 disease. What changes the first line therapy most dramatically? Answer is a validated actionable driver mutation or otherwise a PDL1 or histology, fitness and patient factors guide the treatment. Then about small cell lung cancer, core limited stage treatment principle is platinum etoposide with thoracic radiotherapy for appropriate fit patients. Then about toxicity, if you have a new cough during immunotherapy, first thought, not progression or infection, it is immune-related pneumonitis, act promptly. Then about progression, what should trigger reconsideration biopsy? So you should have a biopsy during progression and test for resistant mechanism. Ask for resistant mechanism in the inches. You will find out what is the reason for progression, then act accordingly. So these are the 10 flashcards for non-small cell lung cancer. Thank you very much for patient hearing.
Thanks a lot, dear Dr. Anoop. It was a truly marvelous presentation, clearly stating the status of lung cancer. Thanks a lot for your professionalism and your excellent presentation. Proud of you. Thank you very much. Dear friends, we are running late, but still we'll try to cover everything in short time. And now let us, it is said that medicine is both an art and science. It's a true fact when it comes to Dr. Rajiv K.R. He's an excellent artist, Kathakali artist, and he is an excellent professional oncologist. Now let us welcome Dr. Rajiv K.R., additional professor of radiation oncology. Let's have quick words on cancer breast. Over to you, Dr. Rajiv. Dr. Rajiv?
Yeah, thank you, Prashant. Let me just share the slide.
Please. As you on top left breast PPT, then make it presentation. Top left, yes.
Can you see the?
Yes, yes. Just to make it in the slideshow, you present. Yes.
Yeah. I'm audible, right?
Yes, perfect.
Yeah. Thank you, Prashant. So as he said, it's the right time to start Kathakali also. Usually we start at the present time. Anyway, it's almost like the same thing that in Kathakali we don't know who all there and whether they are listening or not. Anyway, I'll try to do my level best as in Kathakali. So the next 15 minutes regarding the breast cancer current concepts. And I just wanted to tell you that it's not possible to cover the entire breast cancer update in this time limit. But I wanted to tell you what you people should be aware when you see a breast cancer patient. So as you know, breast cancer remains a global problem. It is the most common malignancy in female, and it's the second most common malignancy altogether. And it's also one among the biggest malignancy regarding the mortality is also concerned. And when it's come to the breast cancer scenario, uh, almost the word screening means limited to some common malignancies. And the first of all, we think about the breast cancer, and I'll tell you why. And it's an organ where you can try to do something known as early detection, and where we should clearly understand that the screening and the early detections are two different things. The screening we do in normal individual, and the early detection where we do it in a symptomatic individual. And then we'll talk about the management of the breast cancer disease. So when we discuss about the screening, there are five major tools by which you can do the screening. One is self-breast examination, second is a clinical breast examination, third is radiological investigation, which is mammogram, and also ultrasound and MRI. So these are the five modalities by which you can do screening. But before start doing that, what should we do when you see a normal woman comes to you asking for a screening? The first thing is not to write for any investigations, but taking a small bunch of informations in your hand, try to put this particular lady, whether she is in low or intermediate risk or a high risk individual, to develop breast cancer. That is your first job, not to give any investigations suddenly to write a mammogram or an MRI to see whether this particular lady has got a breast cancer or not. But to get this particular idea about that particular individual's risk, you should know what are the modifiable and non-modifiable risk factor for an individual to develop breast cancer. So modifiable means you can try doing something to reduce that particular risk factor. So obesity, especially in the postmenopausal age group, and the hormone replacement therapies, and of course the habits like smoking and alcohol. So these are some of the important modifiable risk factors that you have to ask. Then the non-modifiable risk factors where you can't do anything. Being a female itself is a risk, and also the advanced age, and starting menarche at the earlier age, and menopause getting at the later time, exposing the individual to higher estrogen levels in the body, that is harmful. But you can't do anything on that. So you have to ask the particular lady regarding all these points. Then you will get some idea whether this particular individual falls into a high risk or a low risk. Then you have to think about this particular lady. She has gone one step ahead of all these particular conventional thought of having a risk, and she thought about genes, and that has ended up in double mastectomy, and which is called as Angelina's effect. So, as we know, as all the previous speaker told you, that cancer is a genetic disease. So that is true. So we don't know which all abnormal genes which is going to develop cancer in your body, which is sleeping in your body right at this moment. It is very difficult. But it is true that cancer is a genetic disease. So is it possible to test all the genes in a particular normal woman and to say her or to her family that you are having a cancer gene so that you are going to develop a cancer. Absolutely difficult. So, as far as breast cancer is concerned, there are some high penetrance genes, which is called BRCA, which is BRCA1 and 2, and P53 and P10. But if you test these 3 genes and say that, if it is negative, that, you are not going to develop breast cancer, absolutely not feasible. Okay, so you have some moderate high penetrant genes. And is it possible to test all genes? Yes, absolutely fine. You can go to lab and you can get all these genes done, tests done. But is that tells you that you are going to develop breast cancer, or that is the end of all your tests? Absolutely not. So that is where you need to have a proper genetic counseling lab or clinic where the woman should get a proper idea about her risk, her history, her family, her genes, and then to have a proper route by which we can screen the individual. Fortunately or unfortunately, we don't have any such lab in Kerala as such now. So now, regarding the common screening tools, where we say that the woman should do self-breast examination. But currently, from all the clinical trials, we know that self-breast examination is not accepted as a routine screening modality. But woman should aware about her organ, what is normal and what is abnormal. So she should know in which all position she should place her hand or look to the breast, which is normal and which is abnormal, whether her nipple area complex is involuted or pulled back, or is there any lumpiness. And she should know how to place her hand, which has to be straight, and with the palms, she has to scroll in a clockwise or anti-clockwise manner. It is physician's responsibility to teach the woman how to do that. So, which is called breast awareness. So, the word self breast examination has changed to breast awareness, being familiar what is normal and abnormal to a lady. And when it comes to a clinician, regarding the clinical breast examination, the clinician should be able to take the patient and undress properly and to see whether there is a skin dimpling, visible lumpiness, whether there is a purity orange. That shows that there is a blockade of dermal lymphatics, and that is a sign of a locally advanced disease. Whether there is an erythema, ulceration, nipple invasion, whether there is a blood-stained nipple discharge, that tells you that it is not, it is malignancy. No, absolutely not. There are some other conditions where you can get bloody nipple discharge called atelectasia and something like that. So it is the clinician's responsibility first to properly take the history, then to have a proper examination for seeing all these findings. Then, if you suspect malignancy, or if you feel, that I'll tell you in the coming slides, that the patient should or the woman should go for a radiological evaluation, that has to be the mammogram. So mammogram is a simple test, radiological test, where the woman will be standing and you will get a radiograph, something like this. And the shadow which you are seeing in the corner is the axillary pad of fat, and the glandular breast tissue will be either in dense or a very glandular. In the dense breast tissue itself is a risk for developing disease like fibroadenosis, and all difficult thing is to get a malignant lump in between these dense breast tissue. It's going to be very difficult. That is why many of the time the radiologists go for an ultrasound along with a mammogram to confirm the finding. And finally, they will give you a result like this, which is a scoring system for the radiologist. But for us, up to 3 is non-malignant, and from 4, it is a suspicious. And if it is 5, you have to highly suspect it and do some FNAC or biopsy to confirm that it is malignant. Now, what is the role of MRI? MRI is not routinely recommended for all women to know whether they are having breast cancer or not, but it is recommended for high-risk individual where the woman is having a positive gene. So that directly goes to the woman for having a high-risk disease or a high-risk status, and that is a situation where you can consider MRI of the breast. And there are a lot of other situations once they develop the disease to have the MRI, like young women with dense breast tissue. Now, fortunately, India doesn't have any proper screening guideline. As Madhu told us in the first talk, there are some recommendations, but we don't have any guidelines as such. So what does WHO say for the women aged between 4 to 49 is that WHO is against implementation of population-based screening programs. Now, what is the problem is that when you do some regular investigations, that creates unwanted confusions or anxiety in these patients, and that will be more harmful. So clinical breast examination is recommended as a low-cost screening method. From the age 50 to 69, yes, you can go ahead with clinical breast examination along with the mammogram, but the interval is also important. So that has to be once in 2 years for a normal mammogram individual, because doing it frequently may pick up some false positive findings that will end up in doing repeated biopsies. And women aged 70 to 75, again, WHO is against implementation of the population-based screening program. So what we have in India is some guidelines from the ICMR that says awareness and education of women regarding what is normal and abnormal. And the clinical breast examination combined with the diagnostic ultrasound in Indian scenario is good enough, especially in women younger than the age of 50 years, where the breast tissue is dense. So screening mammography has to be there more than the age of 50, and many of the different guidelines says age from 40 onwards, and the frequency has to be once in 2 years. And this is an important aspect where Thiruvananthapuram breast cancer screening study, this has been done with the help from lot of volunteers in Thiruvananthapuram only from different panchayat. And this is a TBCS study which has clearly shown that if we can do this compared to the control group, there is a chance that we can reduce the mortality from the breast cancer. So it is possible to have early detection also. So when you see a woman, think whether average risk or high risk individual. If it is an average risk woman, between the age of 25 to 40, clinical breast examination every 1 to 3 years, from 40 to 74 years, annual or biennial mammogram. In a high risk individual, annual mammogram or MRI based on the tests available, and also the screening should begin earlier, preferably more than the age of 30. And clinical breast examination, it is better to have it in 6 to 12 months. So breast awareness rather than breast self-examination is recommended by most guidelines and prompt reporting to the health faculty. Now we'll move to the war against the breast cancer, that once the women diagnosed to have a breast cancer and come to you, what should be the thought? See, you can think about the scenario into 3 headings. One, the woman can be having early stage breast cancer, or she might be having a locally advanced breast cancer, or she might be having a metastatic breast cancer. Now, the common trend for any general practitioners, whoever it may be, to think about surgical treatment for a breast cancer. Yes, that is true, but it is always unethical to suddenly jump into the excision of the lump, or to get this lump out without having a proper clinical examination and imaging finding and to a diagnosis. So this is what happens for a lady. If you do some piecemeal excision, the oncology will not be getting a proper stage to have a proper treatment ahead. So never ever do excision of the lump without having a proper imaging and a biopsy confirmation. So what should we do? So you should have a clinical evaluation, you should take all the history, and you should go for the imaging next, either a mammogram or an ultrasound. And if it is suspicious, you should try doing an FNAC or a core biopsy. And if the core biopsy is inconclusive, you can go ahead with a repeat core biopsy. Still it is inconclusive, then the surgeon has to go ahead for the planned wide excision. What does it mean? The surgeon should take it out with a negative margin at least. So that has to be the no. Now, coming to the treatment, whether should we do surgery or should we give chemotherapy, when should we give radiation, that is a difficult scenario for the oncologist, but it is quite simple. All the early stage disease, you can directly go ahead with surgery, no issue. Now, the question of what surgery? Should we take out the entire breast or can we have the organ conserved? Always the first priority should be for the patient. It is not for the doctor to take a decision that, oh, don't keep the breast, do the mastectomy. No, it has to be the patient preference. Then the doctor think whether that is feasible or not. Can we preserve the breast? If it is the patient preference is BCS, breast conservation surgery, and the doctor also feels that that can be done, yes. But if the doctor feels that that is not feasible because of so many conditions in which you are not supposed to go ahead with the conservation surgery, then you should go ahead with the mastectomy. So it has to be the responsibility of the physician to counsel the patient accordingly. Even if you do mastectomy, there are a lot of options to reconstruct the breast tissue from the different flaps. And regarding the axillary treatment, always the problem is regarding the morbidity, that is lymphedema. Nowadays, we rarely come across a lady with lymphedema because the surgical treatment has totally changed, the radiation treatment has totally changed. We started respecting the axilla, and that is why the thought of whether we should do routinely axillary clearance in all the women. So there is a thought that which patients benefit from complete axillary lymph node dissection and what are the indications for avoiding completion axillary lymph node dissection by way of a sentinel lymph node. That is, sentinel means gatekeeper. You can consider, you can identify the initial lymph node, and you can check whether that is positive or not, and you can decide whether you need to do axillary dissection or not. That has to be on a case-by-case basis. So sentinel lymph node biopsy will actually guide you whether you can avoid axillary dissection. Even if there is a micrometastasis, still you can avoid axillary lymph node dissection. But of course, when there is more than 3 sentinel lymph node that is positive, yes, you can go ahead with axillary lymph node dissection. But it is also the responsibility of the radiation oncologist should know what has done to the axilla. Then he should not burn the axilla on the top of axillary dissection. Now, once you get the pathology after the surgery, the situation was quite easy in 1970s or early 80s because the cell was quite simple. Now the cell is quite complicated for an oncologist or for a general physician to consider what is right, what is wrong. So most of the time the physician have no idea. So what does the particular cell means? So to make it very simple, the earlier approach was whether it is a node negative disease or node positive disease. But the new approach is 4 different molecular types, which called luminals, which means it is good. Triple negative, it means it is bad. HER2 positive is also known as high-risk disease. So luminals means the hormone is positive. The triple negatives means everything is negative. HER2 means that a particular protein is positive. So what is the concept change which has happened? I'm not going to read all these slides because of the paucity of the time. The breast cancer became a systemic disease rather than a local regional disease. So that is the concept why the women always ask, the family asks, oh, my breast has been removed, so why do you want to give me chemotherapy or hormonal therapy? So that is just because the breast cancer became a systemic disease. So what do you mean by systemic therapy? It can be chemotherapy, targeted therapy, or hormonal therapy. So now for an early stage breast cancer, how do we take a decision whether the patient requires chemotherapy or hormonal therapy? How do we take a decision? First of all, we should know whether there is only an in situ cancer, just an early stage event. or the woman is having an invasive cancer. In situ cancer means it has not breached the basement membrane and where there is no indication for chemotherapy. You can just get away with locoregional treatment as well as hormonal treatment if it is hormone positive. But if it is invasive cancer, then the prioritization comes whether you can avoid chemotherapy. That has to be based on a lot of pathological finding, including the genetical status of that particular individual. That is specific only for that patient. It may be different for a different patient. So the personalized medicine or a molecular based medicine is the key to take decision whether the patient requires chemotherapy postoperatively in early scenario. So, which is called adjuvant. The word adjuvant means any treatment that you deliver after a definitive treatment. So, in breast cancer, definitive treatment is going to be surgery. So, adjuvant chemotherapy, hormone therapy decision based on prognostic factors. That means you can prognosticate what is the risk of relapse to this patient. You can predict whether the treatment is going to be effective or not. So, you have to check the patient and disease characteristics. What is the absolute benefit with which you are going to give the patient the benefit of chemotherapy or hormone therapy or whatever. And always you have to think about the side effects with all these treatments, by which you can risk group the patient into low risk, intermediate, and high risk. All the low risk patient you can avoid chemotherapy, or the high risk patient you may have to go for chemotherapy. Intermediate risk patient you have to take the other clinical factors to take the decision. Now that is based on the all these factors to have the treatment decision. Now, all the women, I have never come across any girl or woman saying that, oh, chemotherapy, I am most interested, give me the chemotherapy. No, all women are afraid of chemotherapy, but it is physician's responsibility to teach them what is their risk and what about chemotherapy, what are the side effects, what are the benefits. So when you teach them regarding the benefit and about the toxicity, they will be able to comply with the treatment. So I'm not going to the details of the chemotherapy regimens. Earlier we have cyclophosphamide, methotrexate, then it has come to anthracyclines and taxanes. Even now anthracyclines and taxanes remains the backbone of chemotherapy in breast cancer. Now, what is targeted therapy? Which is called otherwise called biological therapy. It is targeting a particular protein, and mostly in breast cancer, it is the HER2 protein, which is the transmembrane protein, and anything which you give to block this protein is called anti-HER2 therapy. And now the thought process are, in what all situations you want to escalate the anti-HER2 therapy, what all situations you can de-escalate the anti-HER2 therapy, because you can block the HER2, you can get the benefit. At the same time, you have to reduce the toxicity. So whether you want to give a longer duration of trastuzumab, currently only 1 year is considered as the standard. No, more than 1 year is not required. And dual anti-HER2 means more than trastuzumab, you can add pertuzumab, TDM1, naratrib, a lot of other anti-HER2 therapies in a wise manner, in a wise situation. So what is the de-escalation? Can you reduce the anti-HER2 therapy to 6 months or 9 weeks or vice versa? So that has to be individualized in each patient. And don't think that it is without side effects. Everyone says that targeted therapy or immunotherapy are totally away from side effects. Absolutely no. So you can find this traffic signal where the targeted therapy, trastuzumab, causing the cardiotoxicity. So you have to monitor with echocardiogram, and you should know when to start and when to stop. And coming to the radiation therapy, this again is a local treatment to breast cancer as same way as surgery. And radiation treatment in cancer has evolved from cobalt to linear accelerator and much more conformity like a surgeon does the surgery. Now, once the woman has mastectomy, what are the indications to give radiation? If it is a T3, T4 disease, or more than 4 lymph nodes in the axilla positive, or 1, 2, 3 nodes positive with some other adverse factors, or margin positive disease where surgeon says that further resection is not feasible, or some residual disease where the surgeon again says that further resection is not feasible. These are the indications to give radiation after mastectomy. Now, it's a very complex procedure. Surgeon can see and do the surgery, but unfortunately, radiation oncologists can't see anything because it's high dose X-rays. So where you have to get the benefit. You have to get the help from the imaging. You have to take the CT. Then you can clearly see the breast tissue as shown here. You can see the lungs. You can see the heart, and you can plan the radiation accordingly to accurately deliver the dose to the breast without having much dose to the lung and the heart. Now, the radiation therapy remains to be an important part of the adjuvant therapy in breast cancer. Why? It improves the regional control, and the modern radiation therapy techniques requires good imaging, and you can deliver precision radiotherapy that you require accurate radiological anatomy. So that is why the radiation oncologists always go behind the images. Now, why do you want hormone treatment in breast cancer? The earlier days, the only available treatment for breast cancer was just oophorectomy, because the George Beatson has clearly shown oophorectomy on a premenopausal patient in an unresectable breast cancer has shown a complete remission and survived another 4 years. So that was a landmark in the breast cancer treatment, that hormonal manipulation benefits. So you know that around 75% of the breast cancers are estrogen receptor positive and characterized by late risk of relapse even after years. And the long-term risk of recurrence is about 1 to 2% per year. Even 50% of the recurrence occur more than 5 years after diagnosis. So when you think about hormone therapy, you divide the woman into two. Is she premenopausal or postmenopausal? Is she premenopausal? The available treatment are two. One is tamoxifen, all the medicine. It is 20 milligram given once daily for 5 years for low risk individual. For high risk individual, you can continue even up to 10 years, or you can make the premenopausal woman postmenopausal by doing something known as ovarian function suppression or ablation, and you can either continue tamoxifen or you can change to some other medicines which is called aromatase inhibitors, which include letrozole, exemestane, anastrozole, etc. Coming to the postmenopausal status, if it is a low risk postmenopausal status, you can still go ahead with the tamoxifen, but all the high risk group go for aromatase inhibitors for 5 years. And there are some situations in high risk group where you can continue aromatase inhibitors for 10 years. So the patient is under our vigilance for 10 years period, looking about the benefits and the side effects. And nowadays, there is something called as cyclin-dependent kinase inhibitors, which acts along with the endocrine therapy in very high risk individual to reduce their recurrence rates. Now, you should not think that the hormone therapy is totally without side effects. This is an interesting paper which has clearly shown that hormonal therapy with a lot of side effects. So you might be seeing many patients on breast cancer treatment post 5 years or 7 years or 3 years coming to you with all these issues. So don't tell them that, oh, you are absolutely fine. It might be because of all these endocrine therapy. They might be having cognitive dysfunction, depression, anxiety, distress, insomnia, bone density loss. And I personally know many of these good family relationships are gone just because of these simple tablets, because the patient get frustrated. So the proper counseling, psychological support, and all these available treatment, including yoga and other modalities, are essential for these patients, which can be given by a general practitioner. Now, what about locally advanced breast cancer? Yes, there is something called as neoadjuvant systemic therapy. The word neoadjuvant means any treatment that you deliver before the radical treatment. That can be chemotherapy, targeted therapy, endocrine therapy, or immunotherapy. Then you downstage or shrink the tumor, then you consider surgery, then you give radiation. So that is the norm for a locally advanced breast cancer. Along with that, you can add hormone. If the receptor is positive, you can add targeted therapy, or you can add immunotherapy. I'm not going to give you the details of all the treatment. Now you finish the treatment for an early stage or locally advanced treatment. The follow-up has to be first 2 years. It has to be every 3 to 4 months, then every 6 months up to 5 years, then annually. And mind you that no investigations other than clinical examination is recommended in each visit. The only thing that is recommended is a bilateral or a contralateral mammogram during visit. And when the woman is symptomatic, then you can do PET CT or CT or ultrasound, whatever, or bone scan, whatever is required. Now, the word metastatic disease, as Madhu has already told you, that was a death sentence in earlier days as incurable disease. Yes, that is true even now, but for a selected scenario, as all as told you, that oligometastatic disease, still you can consider a curative intent. We do see patient with brain metastasis or liver metastasis or lung metastasis going happily with good quality of life after 10 years of their time span. So how do we take a decision in otherwise stage 4 disease in a metastatic scenario? The first and foremost point is performance status. In a poor performance status patient, don't think too much on the treatment. Think about the age of the patient, what is the life expectancy, think about the comorbidities, think about the patient preference. Always talk to the patient and ask her what she wants. And also the disease characteristics. Is she in a crisis? Is she in an effusion? Is she having multiple bone fractures? So you have to think about the tumor biology. Is it an aggressive disease? Is it a hormone positive disease? So if the patient is not in visceral crisis, if the patient is in hormone positive disease, you need not jump ahead with chemotherapy. You can continue the treatment with hormonal treatment, and you have to see what is the patient's disease-free interval once the patient cured of the initial treatment, then when she has relapsed. If it is a long relapse, you can again go ahead with multiple treatment, and you have to also think what all the treatment that patient received earlier. And if the patient is in poor performance status, if the patient has got so many visceral issues, and do you think that there is nothing more I can do? No. As doctors, we have a responsibility to the patient. That is, there is always something I can do. And my request is for an advanced stage disease, this should not be our norm to terminally cancer patient to treat like this away from their health, their caregivers, and this should not be the norm for the patient with stage 4 disease with extensive metastatic disease. But we can do something like this, where all the physicians, all the treating doctors, all the normal human being can give a good quality of life till the patient leaves. So the past was your doctor makes an educated guess about the pace of the disease and treats accordingly. You and your doctor regularly assess the benefits of specific treatments and adjust accordingly. But now and future, your doctor tests your cancer and your normal cells. You and your doctor rationally select therapy predicted to control or cure the disease. Thank you.
Excellent words for your speed, rapid action in your presentation, dear Dr. Rajiv. We are still a bit late. We'll quickly go to the another, great session by an eminent expert, Professor Dr. Ashwin Kumar from Department of Radiation Oncology, speaking on male genital cancers. He's again a man, a perfect teacher, a man of an extreme commitment, a passionate teacher, and a very nice, approachable doctor. And hearty welcome, Dr. Ashwin sir. Ashwin sir. We'll get back to Dr. Ashwin. If there is it seems there is a technical problem. We'll quickly go to Dr. Lakshmi Haridas, yet another passionate doctor, speaking on additional professor in Department of Medical Oncology and Regional Cancer Center, speaking on female genital cancers. Dr. Lakshmi.
Yes, Prashant. I'll share my screen.
Sure.
Is the slide on the slides visible, Prashant?
Yes, yes, yes.
So thank you, IMA and Prashant, for giving me this opportunity. I'm very confused whether I should say good evening or good night or something. So I won't be taking much of time because it's already 10:30. So I'm going to talk a bit on gynecological cancers. I'll try to stop in 10 to 12 minutes. So what a general practitioner should know beyond a cervical cancer? We'll be seeing what are the red flags concerning the disease, what are the screening modalities available, what is the referral, when is the referral, chemotherapy, radiotherapy, emergencies, and the survivorship. So this slide deck actually built upon GP decisions. We are not going to deal with the detailed staging or the chemotherapy protocols. We will stick ourselves to recognize how a woman or which woman who needs screening, who needs an urgent examination, rapid referral, toxicity care, and of course survivorship issues. So our goal will be to treat. Whenever prevent when where possible, to screen the community correctly. Do not falsely reassure the community. Act fast on treatment toxicity and keep the survivors functioning with a good quality of life. So these are the five major histological or the anatomical areas where we are going to deal with cancer: cervix, endometrium, ovary, vulvar, vaginal, and of course gestational trophoblastic neoplasia. So we should remember that cervical cancers are HPV driven. Is there a screening available? Yes. We can detect it with the visual inspection, pap smear, and HPV dependent testing. All the other cancers, I'm not going to the details of everything because this will be available in YouTube. So just main points are there of these five cancers which we are going to deal with. Cervical cancers are the one where screening exists. No other, all the other 4 or 5 diseases do not have a population screening strategy as of now. So before going on to the topic proper, just to quickly know the anatomy, this will help us to know the symptoms or be alert on the symptoms of each of the disease. So endometrium, it is very easy. It is a postmenopausal bleeding or an abnormal uterine bleeding. Ovaries, ovarian cancer or tubular carcinomas, they will have IBS-like symptoms, which will be very vague. Actually, that is the catch in ovarian cancer. We'll be having vague symptoms like bloating, early satiety, pelvic or abdominal pain, urinary frequency. And cervical cancer, especially when a patient is having a bloodstained discharge, bleeding per vagina, abnormal cervix, and or a postcoital bleeding. Vulvar vaginal symptoms will be again similar. We can see on inspection, the patient will complain of an unexplained bleeding per vagina. Of the cycles, when we examine, we can see or the gynecologist can see an ulcer there, and there will be persistent itching symptoms. So the teaching point in this slide is that symptoms usually point to the organ with bleeding, bloating, and or lump, and of course treatment toxicity. So we said we have only screening for cervix. So what is that? That is an average risk screening is available in India. That is from 30 years onwards. There is every 5 years we should do a visual inspection where it is program based, and HPV based screening is also preferred whenever there is available. So even when we say there is an average risk screening modality existing for the cervical cancers, we should vaccinate, screen the population, refer abnormal results, and examine symptoms even if the smear was normal. That is very, very, very important. I want to stress this point. The one take-home message from this slide should be, even if the pap smear says it is negative, if the patient has symptoms, you should refer. So wrong screening is harmful. It creates false reassurance, false positives, anxiety, and unnecessary procedures. For endometrium, ovary, vulvar, and vaginal and gestation trophoblastic neoplasia, there is no population screening. For them, you ask for the symptoms and do accordingly. We will come to that later on. So cervical cancer, it is a preventable one. We said there is a Indian screening program available. So WHO direction also gets us to another point. So in otherwise it is starting from age 30, but in people who are living with HIV, the screening should start by the year of 25. So never forget, and a symptomatic woman needs speculum examination and referral as indicated. There is no role for screening for such symptomatic patient. A normal pap smear does not rule out cancer if the cervix looks abnormal. So in that kind of patients, even if the pap smear is normal, the gynecologist should examine her under anesthesia, see where the lesion is, do the colposcopy, and do some kind of a leap or conization procedure when as per the lesion's status. So again, the Indian vaccination guidelines starts for children, girl children above 9 to 14 years of age with a single Gardasil 4 program. So there is a catch-up counseling also. So as a general practitioner, we should always be aware of the HPV vaccination. And when we talk to the patients individually in the clinic also, we should be aware that the best immune response and maximum cancer prevention is when the cancer vaccine is given in early adolescence, that is before the sexual debut. And do not ask judgmental sexual history questions, and treat HPV vaccination and cancer cervix as a cancer prevention vaccine. Like we say that hepatitis B will protect you against HCC. So, but vaccination does not replace screening. That means that even when the children or the women, young women are vaccinated, it does not get away that you will not need cervical screening. They still need age-appropriate cervical screening. So, early recognition and referral. We should be aware of the red flags of each of the anatomical sites where the cancer we are going to discuss, so that if there is a red flag as per the symptoms discussed, we should refer them. So in a cervical cancer, the action should be, if there are symptoms like this, you should do a speculum examination and urgent gynecological referral. If there is an abnormal speculum examination, please do not wait for a smear report. You just refer to an expert. Endometrial cancer, again, any vaginal bleeding more than 12 months after the last menstrual period needs evaluation. By and large, it is mandatory because spotting counts. Postmenopausal bleeding is a cancer until proved otherwise. It can either be from the cervix or inside or in the uterine cavity, but every spotting counts. So, but that doesn't. So, if there is a bleeding history, you should examine the patient and confirm where is the true source of the bleeding by a speculum and pelvic examination. If you find the endometrial thickness is high on transvaginal ultrasound, go ahead with the tissue diagnosis and refer urgently. But does that mean that only postmenopausal women needs such priority and urgent referral? No, it is not at all. Premenopausal women are also not exempt. So consider evaluating people who are less than 45 with persistent intermenstrual bleeding, heavy irregular bleeding, or risk factors. We know that the risk factors of endometrial cancers are obesity, PCOS, nulliparity, diabetes, or Lynch syndrome. So when a premenopausal patient comes with these risk factors with a intermenstrual bleeding or heavy menstrual bleeding, always be on the watch out for a cancer sitting inside. This we again said, because the practice point is that if a premenopausal person comes with risk factors and a bleeding, you should lower the threshold for when to refer. Even before the menopause, you should refer. So ovarian symptoms, vague is a trap. Vague symptom, that is the word. Vague symptom, that is a trap. So symptoms matter whenever they are new, persistent, and frequent, especially in people who are more than 50 years. So that means the patients would complain of persistent bloating symptoms, they would be under the care of a medical gastroenterologist for that persistent gastritis-like symptoms. They will be on medication for that. So that is a usual history. We can see early satiety or appetite loss. The the gastro people will evaluate and find that it is due to the ascites. They will look onto whether there is a hepatic component for the ascites. Then we can, on imaging, we can get we will get the peritoneal disease or something, and then we get a reference. So pelvic abdominal pain, urgency, urinary frequency, and all are vague symptoms of ovarian cancer. So again, if there is a symptom, examine the patient, do a CA 125 and a pelvic ultrasound, and then urgently refer. So one point I would like to stress, because the primary care of contact for any general population would be the general practitioner. So what we should understand is that if there is no CA 125 annual screening package for any average risk women. CA 125 actually is done for symptoms. When any patient comes with these kind of vague symptoms, CA 125 can aid in your diagnosis, because only 50% of the total burden of ovarian cancer do secrete CA 125 into the bloodstream. So that is not highly reliable in some situations. But if we do that for symptomatic patients, for follow-up visits after malignancy, after the ovarian malignancy has been treated, etc. So vulvar vaginal cancers, patients do rarely volunteer this symptom. They're very hesitant to volunteer and come forward with whatever symptoms they have, like persistent vulval itching, soreness, lump or wart-like lesion or thick plaque, non-healing ulcer, bleeding, pain or discharge. All these women will try to hide, and they will not think that they are significant. So the rule is that unexplained vulvar symptom more than 2 weeks, gynecological examination should be done, and if there is a visible lesion or ulcer, biopsy and urgent referral. GTN is close to all medical oncology people's hearts. So I would like to put a word on this. These are rare diseases in India, but it is the one disease which is highly curable. I would say 98 to 99% are curable. So when to suspect? A young patient with persistent bleeding after a failed pregnancy, be it molar or pregnancy loss or delivery, the uterus is larger than expected, very high or plateauing beta HCG, or if the patient is having hyperemesis, thyrotoxicosis features in a molar pregnancy. So when such a patient comes to the clinic, do not reassure without checking follow-up. Do not take these things light. Check serial beta HCG monitoring should be done. Contraception should be advised during surveillance, and if the beta HCG value rises or just plateau, they should be rapidly referred to the cancer center. So any pregnancy event, molar pregnancy, miscarriage or delivery, if the serial beta HCG monitoring fails to put the beta HCG value as normal, depending on the lab value, and there is a plateau or rise, always think of a possible GTN and refer immediately, because these are highly curable cancers. This I'm going to say because of lack of time. So how do we confirm the treatment from a primary side? So endometrial sampling is, of course, needed. That can be very well done. Cervical or vaginal biopsy, yes. But for GTM, there is absolutely no biopsy. Biopsy is contraindicated, because we will get the disease status by the beta HCG values. We do not actually need a tissue diagnosis. And if you go for a tissue diagnosis, you will end up in torrential bleeding and the patient will be lost. So no biopsy for GTN. And one word about ovarian mass biopsy. When an ovarian mass, you find an ultrasound or CT, there are situations where you should avoid a biopsy, because if the surgical oncologist or the gynecologist have been consulted, and the opinion from their side is that complete cytoreduction can be done, the biopsy should not be done. The biopsy, that pre-biopsy, always we will check for a biopsy at some point, and then we will go for a curative intent of treatment, being in surgery also. But ovarian mass, localized ovarian mass, which can be completely removed by a staging laparotomy as per the consultation of an expert oncosurgeon, but ovarian mass should not be biopsy, because you are going to upstage the disease. So what are the treatment options? In a very nutshell, ovarian carcinomas are treated with, we know, both modalities, chemotherapy and surgery, along with, in the last 5 years, we are talking kind of maintenance treatment with targeted therapy. You would have heard of the term PARP inhibitors, which is in the front line for the maintenance treatment of ovarian carcinomas. Endometrium, again, surgery is the prime modality of treatment. Depending on the surgical pathological report, we would stage the disease and decide whether the patient needs radiation alone, radiation and chemotherapy, and of course immunotherapy is also being incorporated into endometrium management in the last 5 years. Cervix, again, early stages we should do surgery. or if advanced, it's most of the time it's going to be a combined modality of treatment, that is chemo and radiation. And in metastatic stages, always it is a chemotherapy. GTN is always treated with a chemotherapy. There is no role for surgery except in few situations, but that is not the prime modality of treatment. It is always chemotherapy. And a word on node dissection and sentinel sampling. In endometrial staging is very upcoming molecular pathology, and all are being incorporated into C endometrium staging. So that means sentinel lymph node biopsies are also the major part of NC endometrium surgical procedure. So always it is better to have a guidance or an expertise in the field to take a patient with confidence. So next is whenever the patient relapses. See, carcinoma ovary patients are destined to relapse. 75% of patients are destined to relapse. That is true, but relapse is not the end. Many of the times our patients come and say that, oh doctor, we have got a relapse, so that all hope has gone and all that. So from the doctor side, we should all reassure, we are living in 2026 era. So that means that relapse pattern is treatable nowadays, and this survival has even improved much more with a good quality of life. So this, I've just taken the epithelial ovarian sample for just the crowd to understand what did I quantify for. See, the first line management of advanced advanced ovarian carcinomas in 1950s was only 10%. Slowly you can see the graph coming up, and we are in 2025, 2026, where the 5-year survival is 65%. In the recurrent disease, where the median overall survival was 3 months, now it is 3 years in 2025. So that means that we have lot of relapse treatment options, lot of maintenance options, lot of targeted options, lot of immunotherapy options, so that we can keep the patient go with good quality of life and good symptom control. So during treatment, we know the surgery, chemotherapy, radiation, targeted therapy, on all immunotherapies do have some toxicities to the patient. So whenever we give chemo or whatever we administer, and then they go out to the community, when they go back to their home and we ask them to come for the next visit, it is the physicians who are going to see them for small things, and we should be aware that platinum taxane is the main chemotherapy which we are using in gynecological malignancy. So that is prone to cause neuropathy. That is very burden. That is a very symptomatic burden for the patient, because people who are diabetic are more prone to get neuropathy. So always insulin dosage adjustments and glycemic index keeping it's normal, that are all in your hands. So neuropathy, nausea, cytopenias, fever and all should be managed. And bevacizumab, again, hypertension, proteinuria, bleeding tendencies, etc. And whenever the patient is if some patient is on PARP inhibitor, comes to your side and they complain of fatigue, always it would be due to the anemia the PARP inhibitors have caused in them. And if you find there are any persistent cytopenias, urgently refer, because they have a small risk of 1% risk of having transformation to acute leukemias. Checkpoint inhibitors, I think Anoop has already told, you can hit any part of the body and cause autoimmune related symptoms. So any new symptom for any patient who is on immunotherapy needs further check mechanisms. So this is the 60-second OPD triage for any patient who is on active treatment. So ask whether the patient do you have fever? Are you breathless? Do you have diarrhea? Do you have bleeding? Or is it that you can't drink? Do you have neuropathic pain, spinal cord compression? These are all alert signs where where the emergency department should be alerted and the patient should be referred. This I'm going to skip. But just a one febrile neutropenia. If the absolute neutrophil count is less than 500 and the patient is on chemotherapy coming to you with fever, it is febrile neutropenia. So any hypotension, altered sensorium, breathlessness, mucositis, renal dysfunction are all are alarming signs where we should understand that the patient has gone into a septic shock, and the first dose antibiotic should go immediately, and then should be managed appropriately and should be referred. Diarrhea actually can be due to so many factors. So it can be due to radiation, can be due to chemotherapy and immunotherapy. I'm going to skip this. So again, radiation is an integral part of gynecological malignancy treatment. So bowel disturbances, bladder disturbances, skin, fatigue, vaginal symptoms, nutritional hydration, all can be affected. So any patient with diarrhea, urgency, proctitis-like discomfort on radiation therapy or immediately after radiation should be reviewed with utmost importance. This one, survivorship issues, the general practitioner should actively ask about is vaginal stenosis, sexual dysfunction, if there is a premature menopause, because most CA ovary and CA endometrium patients are going to have the surgery which encompasses BSO. So they will have a menopausal symptoms. Again, if the patient has gone for a pelvic lymph node dissection or a parietic node dissection, they will have lymphedema, they can have bowel fibrosis, and of course, nothing more significant than a psychological health counseling and a cardiac issue monitoring with management of obesity, diabetes, blood pressure, smoking cessation, and exercise should be with caution. So this is a scenario where a 38-year-old woman coming to you with a history of recurrent postcoital bleeding, but she says, Doctor, my pap smear last year was normal. The specular examination but reveals a friable cervix which bleeds to touch. What should you do? You should reassure the patient that cytology is just a screening tool, but you have symptoms with a sign when on examination. So do not repeat the pap smear as reassurance. Urgently refer this patient to a gynecology department. So next is 62-year-old menopausal lady with 2 episodes of spotting. She is obese, diabetic. There is no pain. We already talked just spotting after menopause. It's not very light. Take it very seriously, and postmenopausal bleeding is always abnormal until proved otherwise. So every spotting counts. You should evaluate the patient and urgently refer. So IBS after 50. This is what I was referring to, that the vague symptoms, that catch of vague symptoms after the age of 50 should always suspect ovarian malignancy. Fever after chemotherapy we discussed. So this is if the audience does not remember any of my saying of these last 10 minutes, I want you to pick this from my presentation. That is the one take-home message at least. That is missed period in a young lady with breathlessness. So 27-year-old recently married lady coming with missed periods and breathlessness. So always consider the possibility of GTN and proceed with beta-HCG, serum beta-HCG estimation and ultrasound examination. Ultrasound uterus will show the typical pattern of vesicular mode, if that is going to be a vesicular mole of pregnancy. So the one key take-home message of this point is that we should never miss a GTN in a busy OPD because it is highly curative. Thank you for your patient listening.
And thanks a lot, Dr. Lakshmi. We'll have a very quick session on male genital cancers by Dr. Ashwin, Professor of Radiation Oncology, Regional Cancer Center, Thiruvananthapuram. Over to you, sir. Sir, now I think you can share the slides too. Ashwin, sir?
I cannot share the, I can't seem to share the slides.
Sir, please try. There are a lot of people watching through the YouTube channel as well. We are so happy, but so sorry to keep you late. Ashwin, sir, should I share?
Yeah, I think you should.
Okay. Yes, sir.
Okay. Thank you, Dr. Prashant and IMA CGP. I've been asked to talk about genitourinary cancers. Now, most genitourinary cancers present outside a cancer center, and key contribution is not to diagnose every case. You should recognize a single signal, avoid false reassurance, initiate sensible tests, and refer without delay. And the focus of my talk will be on prostate, bladder, kidney, testis, and penile cancers. Can we have the next slide? Now, the prostate is the most frequent urological cancer that we see in our practice. Around 440 patients presented last year to RCC. Bladder and kidney are the second common. Now, testicular tumor, we see about 30 cancers per year. They are relatively rare, but because they occur in the young, and they are curable even with metastatic disease at presentation, and so therefore they are very important. Next slide. Now, as in the peripheral centers, it's very important to recognize that there are certain primary care symptoms that can be mistaken for benign conditions. However, after a due period of treatment, you should suspect cancer. Because of the positive time, I'm not going through these details. Can you go to the next slide, please? It's always important to remember that lower urinary tract symptoms is not just BPH. New progressive disproportionate lower urinary tract symptoms coupled with an abnormal DRE could be prostate cancer. And advanced prostate cancer can present with bone pain, weight loss, fatigue, anemia, renal dysfunction, and neurological symptoms with spinal metastasis. And advanced prostate cancer can present with hematuria and hematospermia. Next slide. Can I have the next slide, please?
Yes.
Now, after a symptom history and review of medications, one should always, patients should always undergo an abdominal examination, the external genitalia, and a digital rectal examination. Serum creatinine should be done when there is obstruction or renal disease. And you should always do a PSA. PSA, it's important not to interpret PSA during an active urinary tract infection or if the patient has acute prostatitis or soon after urinary instrumentation, such as bladder catheterization. The PSA should be repeated after clinical resolution of symptoms. The treatment of prostate cancer depends upon the PSA, staging by DRE, and the grade of biopsy. And it also depends on the MRI findings and the local extent of the disease. Metastatic, can you go back? Metastatic staging should be done by PSMA PET or by a bone scan. It depends upon the volume of metastatic disease, symptoms, life expectancy, frailty of the patient, and patient preference. Can I have the next slide? Now, for very low or low-risk patients, these patients can be placed on surveillance. That means you can just watch the patient and not do anything. And however, if the patient is very keen on treatment, these patients can either undergo surgery or radiotherapy. Intermediate or high-risk localized patients can undergo a radical prostatectomy or a definite radiotherapy combined with androgen deprivation therapy. For locally advanced disease, the treatment is always a long-course hormonal therapy with radiation. And for metastatic disease, it is androgen deprivation therapy with other agents added to intensify the androgen receptor pathway inhibition and plus or minus chemotherapy. For resistant disease, it's systemic treatment, palliative radiotherapy, and supportive care. Next slide. Now, for bladder cancer, visible hematuria could be bladder cancer if there is no clear benign explanation. So the clinical pitfall is do not stop after treating a presumed UTI if the hematuria persists or recurs. Negative urine culture does not make a visible hematuria benign. So after a urine microscopic culture, CBC, creatinine, and blood pressure, review of history of anticoagulants and antiplatelet drugs, patients should undergo urinary tract imaging and should be referred for cystoscopy to the urologist. Next slide. It's always important in the case of bladder cancer to ask about tobacco exposure, prior pelvic radiotherapy, chronic bladder irritation, and long-term catheterization. And it's also important to remember that a normal ultrasound does not exclude bladder mucosal disease. The early signals of bladder cancer are painless visible hematuria, microscopic hematuria, irritative urinary symptoms, and recurrent unexplained UTI. Advanced disease can present with pelvic pain, flank pain, hydrourethronephrosis, renal impairment, and weight loss. Next slide. Now, the bladder cancer, if it is non-muscle invasive bladder cancer, patient undergoes a transurethral resection followed by a risk-adapted intravesical treatment. And the patient should be on scheduled cystoscopic surveillance. For muscle-invasive bladder cancer, patient can either undergo a radical cystectomy with perioperative systemic therapy. Now, new drugs have come into being with drugs like enfortumab vedotin and pembrolizumab, which are frightfully expensive, but they are remarkably effective. Or patient can undergo bladder preservation with chemoradiation. For metastatic disease, the platinum-based chemotherapy used to be the backbone of choice. However, again, immune checkpoint therapy and biomarker-directed treatment have become the standard of care recently. Next slide. Now, renal cell carcinoma usually presents as an incidental finding, as an incidental renal mass which is found on ultrasound and CT. However, the classical triad of hematuria, flank pain, or palpable mass that we usually see in textbooks is rarely seen. Systemic features. Now, renal cell carcinoma used to be called the tumor of general medicine because it can present with a host of unexplained systemic features such as anemia, fever, weight loss, hypertension, or polycythemia. Also with paraneoplastic features like hypercalcemia, erythrocytosis, and hepatic dysfunction. Now, the critical warning is, do not biopsy or repeatedly observe a suspicious solid renal mass. If the renal mass is localized, the patient should undergo a radical or at least a partial nephrectomy. Next slide. For a small localized renal mass, patient can undergo an active surveillance, image-guided ablation, or a partial nephrectomy. Larger tumors undergo a radical nephrectomy. Metastatic disease, combination systemic therapy with immune therapy. Palliative treatment is again systemic therapy with palliative radiotherapy. And as Dr. Lakshmi pointed out, you should always review the symptoms and treatment toxicities, especially fatigue, diarrhea, rash, hypertension, and mucositis. Next slide. Now, testicular cancer occurs in young men. You should always examine, image the patient, and refer. The red flags include painless enlargement, a lump in the testis, altered shape and consistency, unexplained heaviness or dull scrotal discomfort. Advanced disease can present with new gynecomastia, back pain, or abdominal masses. Next slide. Always discuss sperm banking or fertility preservation early in the course of treatment. Tumor markers should be obtained, such as AFP, beta HCG, and LDH before definitive treatment. However, it should be remembered that normal markers do not exclude cancer. Again, never perform an FNA or throughput biopsy in a patient with a suspected testicular cancer, and do not perform a transcrotal excision of a suspicious testicular mass. It should always be a high inguinal orchidectomy. Stage 1 patients can undergo surveillance, adjuvant chemotherapy, or radiotherapy in selected patients with seminoma. And metastatic patients, cisplatin-based chemotherapy, which is highly effective and potentially curative, and residual masses should require specialist assistance. Now, penile cancer, one should avoid repeated empirical treatment of a persistent, indurated, ulcerated, or bleeding recurrent lesion. Penile cancers can spread very easily to the inguinal nodes. So the inguinal node should be examined and documented. Smoking cessation should be encouraged, and you should discuss hygiene and phimosis with these patients. Next slide. Early superficial disease patients undergo topical treatment with radiotherapy, laser, or limited excision. Invasive local disease can undergo partial or total penectomy. This groin node should be assessed, and if found significant, should undergo surgical treatment. Advanced or metastatic disease should undergo systemic chemotherapy. Next slide. So this is a summary slide. For patients with hematuria, require definite exclusion of bladder or kidney cancer regardless of initial UTI treatment. Patients with lower urinary tract obstructive symptoms require active prostate cancer consideration via a DRE and careful PSA examination. Painless lumps in the testes or non-healing ulcers in the penis demand immediate specific surgical referrals and not prolonged observation or needle biopsies. That's it. Thank you very much.
Thanks a lot for this extremely late session, taking the session, sir. Actually, in fact, the Professor Dr. Ashwin Kumar is always there for every doctor. When there are doctors presenting with various, concerns, he's ready online every time. We thank you and salute you for your commitment. Thank you, sir. Thank you very much.
Thank you.
Now, even though we are very late, our veteran, an eminent young enthusiast from Regional Cancer Center is our Deputy Medical Superintendent, Dr. Sugit MT. Over to you, Dr. Sugit. Sugit?
Yes, sir. Just 1 minute.
No problem.
Okay, sir. So, am I audible? Can you see the screen?
Yes.
Okay, hello everyone. Thank you, IMA CGP, and thank you, Prashant sir, for this invitation. So it's so late. I will try to finish. So it was told that I should take 15 minutes. I think I will finish in 10 minutes because some points have already been discussed. So when we come to hematological malignancy, the bulk of the disease is contributed by lymphoma, leukemia, and myeloma. Among this, the bulk is mainly by leukemia. So what are we intend by this presentation? So what are the clues that we get from our clinical examination and the basic workup? Diagnose a hematological malignancy or to suspect a hematological malignancy. Then once you suspect, what are the things that should be done immediately to stabilize the patient? And when to really refer the patient and what all should be there in the reference. And the last part is mainly regarding the supportive care, both during the treatment and also post-treatment, that the patient has completed the treatment, what are the supportive or the follow-up that we should do. And then most important thing is regarding the supportive care that we give at the end of life or palliative care. So most of the hematological malignancy that need a proper history and a clinical examination. To diagnose, to suspect a hematological malignancy, we need a the history evaluation and then a proper clinical examination and necessary laboratory investigation that are available in most of our centers. So suppose a patient has persistent fever and recurrent infections. Along with that, the patient has drenching night sweats and weight loss. And the weight loss is unintentional weight loss. Then definitely these are called the B symptoms that are commonly seen associated with the lymphomas. And these patients usually have painless progressive lymph node enlargement. So in such scenario, you should suspect a lymphoma. Suppose the patient presents with bleeding manifestations, mucosal bleeds, easy bruisability, and it could be like a hematological malignancy, especially leukemia. But like all these bleeding manifestations may not be leukemia, but still we have to keep in mind the differential diagnosis of a leukemia. Suppose patient, especially elderly patient, they present with pathological fracture, and most commonly they present with a collapse of the vertebra, backache, and patient has associated other symptoms or other associated lab findings, then you can suspect multiple myeloma. And then the presence of splenomegaly, hepatomegaly, unexplained cytopenias. So what usually when we have these symptoms, we usually go for a hematological first thing that we will do is a hemogram. So in the hemogram, if there is leukocytosis with anemia and thrombocytopenia, and in the DC there are abnormal cells, and you do a peripheral smear which shows blast, then definitely you can suspect leukemia. Either it may be acute or chronic. In chronic leukemia, most of the time the patients will be very stable, but acute leukemia presents like an emergency. Suppose the patient has back pain, multiple bone lighting lesion, or a pathological fracture, and along with that, the lab findings which shows high calcium, renal dysfunction, and anemia, elevated ESR, AG reversal, all these may point to multiple myeloma. So, from the history, from the clinical examination, and the basic lab test, we can at least suspect a hematological malignancy. So, the three groups of diseases that we mainly deal here are lymphoma, leukemia, myeloma. I mean, this leukemia is common. So lymphoma presents with painless progressive lymphadenopathy with V symptoms, and most of the time, most of the hematological examination will be normal. Sometimes patient can have anemia. Sometimes lymphoma may present with leukemic phase, where these abnormal cells will get into the blood. So we can detect from the blood also. So otherwise, most of the time, lymphomas, they have high LDH. So lymphomas are generally divided into high grade and low grade. High grade lymphomas have a high acute presentation, but chronic lymphomas or indolent lymphomas or low grade lymphomas, they remain in the body. Gradually they grow and later they present with symptoms. So incidentally, sometimes we do a scan, we can pick up a lymph node and it will turn out to be a lymphoma. That is the usual presentation of a low grade lymphoma. But high grade lymphomas, they are aggressive, rapidly dividing. So immediately they will present with some symptoms. So there are situations like mediastinal. There are some clinical warning signs that we should act immediately in lymphoma. That is mediastinal mass with an airway obstruction. Then definitely we should think of lymphomas like lymphoblastic lymphoma or a primary mediastinal large B-cell lymphoma. Or it could be other thymic tumors or even mediastinal germ cell tumors. In elderly, it could be MES or lung cancer also, which can present with the mediastinal mass. Or sometimes the patient with lymphoma can present with spinal cord compression because of the deposit in spine. Leukemia, on the other hand, the acute leukemias, they present their course and the presentation is very rapid. Within 2 to 3 months or immediately, these patients will present to us. And most of the time, they present with infection because of cytopenia or bleeding manifestations. So may have some associated mild hepatosplenomegaly or small volume lymph nodes. And you do a hemogram, you can see the leukocytosis or cytopenia, you can demonstrate the blast. So in myeloma, I have already mentioned, most of them are elderly. They present with lytic bone lesion and crab features that we will discuss. So in lymphomas, what are the, like we mentioned that they present with painless progressive lymphadenopathy. Sometimes lymphadenopathy may be part of infection. If suppose we have a patient with TB, patient can have lymphadenopathy. And patient can have low grade fever, weight loss. So all these nodal enlargements are not a lymphoma. But along with that, generalized lymphadenopathy, hepatosplenomegaly, and patient presenting with on evaluation, patient has anemia, elevated ESR, high LDH, and patient with tumor lysis, then definitely we should suspect a lymphoma. So some in lymphomas, but some danger zones are like when it presents in the mediastinum, with, as I have mentioned, they compass the vital structures like trachea, respiratory distress, esophagus, dysphagia. It can compass the nerves. It can result in collapse of the lung and breathing difficulty. So the mediastinal mass, some lymphomas are very aggressive. Sometimes they present in the spinal cord where they compress the spinal cord and patient can present with weakness. And another site is CNS. CNS involvement can be primary or secondary. As a part of the disease, it can involve the brain, or it may be an isolated involvement of the CNS, which is known as primary CNS lymphoma, where they present with headache, altered sensorium. Sometimes there will be edema and even coning. So these are some emergencies. So the most important thing here, even when you suspect a lymphoma, immediately don't start steroid. We need a biopsy. If you start steroid in a high-grade lymphoma, especially if patient has a CNS lymphoma, we start steroid for edema. This disease is going to disappear and there won't be anything left to take a biopsy to confirm the diagnosis. So the main thing is, whenever possible, unless there is an emergency, don't give steroid, take a biopsy and then give steroids. So the next is leukemia. So generally among leukemias, we have the acute leukemias and the chronic leukemias. The chronic commonly seen are CLL and the chronic myeloid leukemia, but they have an indolent course. But acute leukemias, they present with two extremes. One, they present with very high WBC count. Then it is like when the patient comes, you see take the history, the short history, the bleeding manifestations, then you do a CBC. CBC shows a very high count. You do a differential count. And in that, we can see the blast and you do a peripheral smear, you can pick the diagnosis. So what happens when the WBC count rises? the blood become thick. So the blood flow through the blood vessels will be very slow. So what happens? There will be leukostasis or slow stagnation of blood. The two vital organs that are affected are one is brain, second is lung. So in brain, patient can present with confusion, altered sensorium, seizure, brain edema, bleeding. And in the lung, it may be chest congestion, breathing difficulty, saturation board. Even the patient may need a ventilator support. So what happens on the other hand? The other hand, the patient presents with the pancytopenia. That means hemoglobin, platelet, and WBC count is also low. You see the DC differential count, there is no blast. You see a peripheral smear, the count is low, so there is no blast. In such situation, we have to go for a bone marrow biopsy. In the bone marrow, it will be packed with the blast. So it is known as allochemic leukemia, where blood shows no blast, but in the marrow, it will be packed with blast. And what are the symptoms? Anemia. When there is anemia, patient can have palpitation, fatigue, dyspnea, exertion, giddiness. And due to neutropenia, the patient can have fever and infection. And thrombocytopenia, definitely the patient can have bleeding. So there is another condition which is called acute myeloid leukemia M3, the FAB classification M3 variant, where the patient presents with the DIC. So sometimes the patient can bleed from everywhere. We have seen patient bleeding from the eyes, from the skin, from the ear, GI bleed. So this is an emergency because immediately we have to start the differentiation agent that is called all trans retinoic acid. And why this is important? Because if you take the real world data of acute myeloid leukemia, the survival is between 30 to 50%, and in elderly it is even less. But if you take acute promyelocytic leukemia or AML-M3, the cure rate is more than 90%. Even though it is very difficult to manage, it is highly curable disease. So that is a disease which needs immediate attention and immediate reference. The other problem that happens with most of the high-grade lymphomas and leukemias are tumor lysis syndrome. So when we treat with steroid radiation targeted therapy or even without treatment, when the blast count is too high, especially in acute lymphatic leukemia, that is in children, what happens? These blasts will burst. The contents of the cells will be released. It will have high potassium uric acid. Usually this is excreted through the kidney, but the kidney is overloaded. So what happens? It can result in hyperphosphatemia, hyperuricemia, potassium will be high, hypocalcemia, and renal impairment, which is called by the name tumor lysis syndrome, which need immediate attention. So what about myeloma? As I have mentioned, myeloma is a disease which is commonly seen in elderly. Even in young patients, we have seen myeloma, but it is commonly seen in elderly, and the median age is 60 plus. That is around 70 years in Western population, but it happens a decade early in Indian population. And usually, elderly people who presents with pathological fracture or unexplained hypercalcemia, sometimes renal impairment, unexplained anemia. So when we do the hemogram, there will be anemia with elevated ESR. There will be AG reversal, and you do an immunoglobulin assay, one immunoglobulin will be elevated because these abnormal clone of myeloma cells will secrete immunoglobulin. 95% of these abnormal myeloma cells will secrete immunoglobulins. So that we can detect by S3 serum protein electrophoresis, which will be manifested as a M spike. That if you do a electrophoresis, it has first albumin, then globulin. Globulin has alpha 1, alpha 2, beta, and gamma. In the gamma region in multiple myeloma, you can see in the electrophoresis a thick band that is known as the M band, which suggests the patient probably will be having a multiple myeloma. And usually myeloma is confirmed by either from a lesion you can take a biopsy or you do a bone marrow which shows more than 10% for clonal plasma cells. So these are the 9 oncological emergencies that we cannot wait. One is febrile neutropenia that is already described. Any patient post chemotherapy after 1 week coming to the OPD, patient says he has fever, don't just neglect, do a CBC, clinical examine the patient, vitals, CRP or procalcitonin. If it is high or if the count is low, patient has grade 4 neutropenia, that is absolute neutrophil count is less than 500, or in a nutshell, when the WBC is less than 2000. Immediately start the patient on a broad spectrum antibiotics. That's one thing that at least we can do at the OPD after drawing the culture. And the other is tumor lysis, which you have explained. So there is hypercalcemia. In myeloma, we can see that there is mobilization of the calcium from both. So the serum calcium will go up. So patient can have all manifestations like psychiatric manifestation, abdominal pain, renal stones, altered sensorium. So in such cases, in myeloma, usually we treat with forced alkaline diuresis. We start steroids for the treatment of the disease. That is specific treatment for the disease. Then we give denosumab when patient has renal impairment, or bisphosphonate when patient has no renal impairment, or along with that we may give calcitonin or plasmapheresis. So the other is spinal cord compression, which again we have mentioned. Suppose patient has myeloma, the myeloma deposit may be there in the spine or soft tissue deposit which can cause the compression. Immediately we can give radiation because these are highly radiosensitive. Suppose there is myeloma involving the spine has fractured and the vertebral piece has gone into the spinal cord. In that case, even with radiation, there is no benefit. Immediately we have to go for a surgical decompression. Superior vena cava syndrome is that usually happens with mediastinal mass when it compresses the structures. Immediately, if it is a lymphoma, take a biopsy. Immediately, we can start steroid. And if it is a lymphoma, there is rapid response with the use of steroid. Leukostasis, already we have explained, when WBC count rises, the blood becomes thick. Slow is the blood flow becomes slow. So it happens mainly two common sites are one is brain and lung. And the other major problem with almost all the hematological malignancies, especially leukemia, is major bleeding manifestation. It can be bleed into vital organs, including intracranial bleed. And what happens when the platelet count is very low, the bleed rapidly spreads, so it will be fatal for the patient. And in general, most of the malignancies, whether it is solid tumor or hematological, they have high tendency for thromboembolism. So most of them may in myeloma, many patients develop the deep brain thrombosis. Later, it can embolize to the lung. So when patient has more risk factors, more than one risk factor, when we give, because the treatment of myeloma is mainly targeted therapy, and one of the targeted agents is immunomodulatory drug, which include thalidomide, lenalidomide, and pomalidomide. When we use this drug, there is again increased risk of thromboembolism. So that's why, along with the treatment, we may use, when there are no risk factors, we use aspirin, otherwise we use anticoagulation, either flexing or even oral anticoagulants. Then we should be careful regarding, so when we refer a patient to the local hospital, to look at the count or for monitoring, usually we issue a chart. So suppose it is ABVD chemotherapy for Hodgkin lymphoma, we write the chemotherapeutic agents, adriamycin. Or if it is cisplatin based, we write cisplatin. Why? Because we want the physicians to know that if we have given all these drugs. So anthracycles, when we give, it is now all of us have like the Medscape and all in our mobile, so easily we can search. Suppose a patient after giving adriamycin comes to you with a breathing difficulty. One of the important thing is acute toxicity of the anthracycline, where it can produce cardiac toxicity and cardiac failure. And cisplatin can have sensory neural hearing loss, renal impairment, renal tubular acidosis, severe electrolyte imbalances. So that is why some of these side effects need immediate attention. So these are action to avoid, that should be avoided in a primary care. So if you have a patient with toothache and an lymphadenopathy, definitely first thing will be, it should be a tendon caries with infection, small node. You can palpate the node, it is tender, you start antibiotic. But if there are multiple nodes, generalized lymph node, don't neglect that. And especially when patient has unexplained pancytopenia. If pancytopenia may be due to nutritional deficiency, B12 deficiency, or due to any other cause or infection, but it should be addressed and it should be evaluated. And suppose you do a CBC and DC shows high count, or total count is high and DC shows abnormal cells, and you do a peripheral smear which shows blast, then you have to suspect some underlying hematological malignancy. All these blasts may not be like plasma cells can come into the blood. That is known as plasma cell leukemia. In lymphoma can have a leukemic phase, and it can be an acute leukemia or a chronic leukemia. So it should be properly addressed. And in case of lymphoma, before taking a biopsy, if the patient is stable, kindly avoid steroid, especially in a CNS lymphoma. And as early as possible, and stabilize the patient, and as early as possible, the patient should be referred. The next important thing is, like we know how to suspect a hematological malignancy. What are the clues to diagnose lymphoma, leukemia, myeloma? When this patient comes, what are the immediate things that we have to do? So suppose we have a patient who have failed multiple lines, and now the patient is marked for best supportive care. So what does it mean? It's a myth that palliative or best supportive care means no treatment. It's not like that. Only thing is we have changed our goal, but medical treatment remains active. That means for disease-directed therapy, we go to symptom-directed therapy of end-of-life care, where we actively manage pain. So pain-free, the patient should be pain-free. That's the right of the patient. And we have to treat the symptoms like breathlessness, nausea, constipation, anxiety, delirium, and infection. So whichever the symptom is there, it should be treated. Whichever reversible factor is there, it should be treated. Review the medication burden. When whichever medication has not much effect, it should be removed, and reversible causes should be corrected. So this is in general what I have mentioned. What are the things that we do to or look at to diagnose or to suspect a hematological malignancy from the history, from the clinical examination and the basic lab test. For lymphoma, it may be presence of nodes, progressive enlargement of painless nodal enlargement with V symptom. Leukemia usually presents with cytopenia, blast, and bleeding manifestation, and myeloma presents in elderly patients with bone pain, and patient may have CRAB features. The CRAB is an acronym that is used for the target organ damage, where C stands for hypercalcemia, R stands for renal impairment, A for anemia, and B for bone lytic lesion. So whenever we encounter such a situation, first thing is assess the patient, stabilize the patient, do whatever necessary, and then refer the patient to a facility where these treatments are available. And the best supportive care is an active symptom, means that it should be an active symptom control, communication, and a goal concordant care. It doesn't mean that we are just making sending the patient like without any treatment. That means still there is a role for medical treatment. Thank you.
Thanks a lot, Dr. Sugit. As we all know, we are very, very late, but still we had a very fruitful discussion on understanding of cancer and getting timely updated. I think it has, even though it is late night, it has opened in the eyes of many. From the bottom of our heart, we thank each faculty and each of the delegates still waiting. And we'll be splitting up the videos into the YouTube. As a split up videos, and then we also assure you, I have received around 50 or 60 questions in my personal chat box, which I'll share to each faculty and get back the answers, and we'll make it as a poster and we'll publish in the CGP WhatsApp channel rather than discussing right now. There are very good questions which I have received. In one of the classic questions which I should mention right now is that there are the one general practitioner has told me that I was wondering why biopsy was being done in recurrent cases. Since the biopsy is already proven malignancy cases. Now they said they understood, but they need some more details on histological transformation. And then there are good questions on driver mutations, especially that genetic testing and all. Then tumor biology related questions. There are umpteen number of questions I was just mentioning, and we thank from the bottom of the heart each faculty for your contribution. And your commitment, both from the general practitioner side as well as from the side of the oncology people. The oncological expert, whether it is a surgical oncologist working through the night and the hematological oncologist, we must give a loud round of applause for all the hematological oncologists, where the medical oncologists are working in an ICU format in a non-ICU setting. They are bound to many places, and then the high dependency care and those things. The Modern Medical Profession and Indian Medical Association, College of General Practitioners, we salute you all. Thank you very much, and see you in the next week, next Thursday, with a topic of the time, that is de-addiction. And we will learn about de-addiction, about tobacco, alcohol, and drugs. See you next Thursday. Good night. Thank you.